All right, let's see. All right, so tonight we are going to talk about elimination, our urinary system. Last week we talked about GI. This week we are going to talk about elimination. So the objectives for tonight, we want to be able to describe the basic structures and functions of the urinary system, define the primary functions of the kidney and other structures in the urinary system, identify the changes in the urinary system that occur with aging, discuss tests performed for the diagnosis of urologic and renal system diseases, identify laboratory tests performed to diagnose urologic and renal system diseases. Discuss nursing management for a client undergoing diagnostic evaluation of the urinary tract. Discuss the medical management of clients with common urinary diseases and disorders. Describe urinary retention, indicating appropriate nursing management. Discuss urinary incontinence and appropriate nursing management. Differentiate glomerular nephritis. Discuss the nursing management of a client with a nephrostomy tube. Discuss problems the nurse manages when caring for a client with a nephrectomy. Differentiate acute and chronic renal failure. Explain pathophysiologic problems associated with chronic renal failure, and define the purpose for hemodialysis, describing various methods. Discuss nursing assessments performed when caring for clients undergoing dialysis. Discuss various types of urinary diversion procedures. Evaluate expected client outcomes from common drugs prescribed for urinary diseases and disorders. Utilize available hospital and community resources for meeting the needs of clients with urinary diseases and disorders and their families. And identify components of a teaching plan for a client having a urinary diversion procedure. So our exemplars for tonight, we're going to be looking at the urinary system, voiding dysfunctions, disorders with the bladder and the urethra, particularly urinary retention and incontinence. We're going to talk about BPH, which is a disorder that occurs in our male patients. We're going to talk about glomerular nephritis and renal failure, and also dialysis. So we know that our urinary system is involved in waste removal. Sometimes we combine this system with the male reproductive system, and we call it the genitourinary system, GUS. So when you guys are given a report, usually on your report sheets that you give to the nurse coming on, it'll say GI and GU. So GU is the genitourinary system. Our urinary system filtrates all the toxins and removes them from the body. So you have to think of it as like a filtration and a removal plan of all the toxins in the body. We will talk about a urologist. A urologist is a specialist who deals with the female urinary system and the male genitourinary system. And urology is a specialty. It is a science related to the urinary system. So we know that we need to have proper elimination, proper removal of all those toxins in our body. If not, our body is not going to be in this constant state of homeostasis, which we need. Those kidneys eliminate liquid and solid waste products. They help maintain that water balance. We're going to talk a little bit more about that. It helps regulate our pH, and it produces certain hormones that our body needs. Sometimes we may see a change in our bowel or bladder habits. We talked about a couple things last week about some changes that we saw in our GI tract, a couple disease processes. Well, we're going to talk about some more with our with GU as well. Whenever we see a change in our bowel or bladder habits, it can be a sign of illness, or that change can actually cause an illness. Always want to use standard precautions when we are dealing with Foley's, urine, stool, any kind of drainage coming from a patient. Always use gloves whenever you're coming in contact with any type of body fluid. All right, so what are the main functions of the kidneys? Well, the important ones that we're going to talk about are it produces urine. It filters and eliminates water and waste products from our body and puts it into our urine, and we excrete the urine from our body. It helps maintain our water balance through the different hormones. It regulates the pH of our body fluids, either by reabsorbing certain things, eliminating certain things, or conserving. So electrolytes, sodium, potassium, that hydrogen chloride, and bicarbonate. It produces hormones that help control our blood pressure. So that's our renin. It helps balance calcium and phosphorus levels. So that would be the hormone calcitrol. And then it helps regulate our red blood cell production. So erythropoietin. So it's very common to see patients that have kidney issues to have a low hematocrit, hemoglobin, and red blood cell count. Because if the kidneys aren't functioning properly, then they have these low levels and they can't make blood, red blood cells. Our kidneys secrete prostaglandins. It helps synthesize vitamin D to the active form, and then it also activates our growth hormones. So we know that it manufactures renin and erythropoietin. It's going to form urine, and the bladder is going to store our urine for when we're ready to remove it from our body. The kidneys form it, the bladder stores it. And then again, it eliminates protein wastes, excess salts, and other toxic material. So this is just a picture of your urinary system. The upper urinary tract is going to include your kidneys, your renal pelvis, and your ureters. The lower urinary tract is going to consist of your bladder, your urethra, and your pelvic floor muscles. So the upper urinary tract, that's the kidneys, the renal pelvis, and the ureters. The lower consists of the bladder, the urethra, the pelvic floor muscles. We have two kidneys, one on each side of the body, which extract waste from the blood, help balance body fluids, and then ultimately form that urine. We have two ureters that conduct urine from the kidneys to the urinary bladder. And then that urinary bladder we know serves as a reservoir for the urine. In the average person, it can hold about 300 to 500 mLs of urine. There is always the person that can hold 1,100 or 1,200 cc's of urine. Nurses can certainly do that. But this is just an average. The urethra conducts urine from the bladder to the outside of the body for elimination. So this is your kidneys here, your left kidney, your right kidney. These are your ureters. Here's your bladder. There's your urethra, just to give you an anatomical view of what that looks like. So the kidneys, they are two reddish-brown bean-shaped little organs that lie in the upper abdomen of our body on either side of our vertebral column. The renal cortex is the outer reddish part of the kidney. The renal medulla is the inner part that contains our renal tubules, the loops of Henle, and our collecting tubules. And the blood supply to each kidney, it comes from the renal artery. So this should all kind of be a review from your anatomy and physiology classes. Each kidney has nephrons. Our nephrons are what we consider the functional units of the kidney. They help form the urine, and then the rest of the urinary system works to expel the urine. Each kidney has more than 1 million microscopic nephrons. They are considered the smallest functioning unit of the kidneys. These structures include the glomerulus, the Bowman's capsule, the afferent and efferent arteriole, the proximal and the distal convoluted tubule, and the loop of Henle. So in each one of these little areas, something particular happens. They each have a job to do during the process of eliminating waste from the body. And it's in much more detail in your book, so you guys can read about that. So urine is going to be formed by three processes. So we have glomerular filtration, tubular reabsorption, and tubular secretions. So with glomerular filtration, this involves filtering the plasma by the glomerulus. It filters substances like sodium, chloride, bicarbonate, our glucose, our potassium, our creatinine, water, and uric acid. Then we have tubular reabsorption. This is where the filtrate enters our Bowman's capsule and then moves through the tubular system of the nephrons. At this point, it's either going to be reabsorbed, so placed back into the systemic circulation, or excreted as urine. And if you remember when we talked about in homeostasis, there were certain times if our body needed something, we would reabsorb it because we needed it. And if we had too much of it, then we would, or enough of it, then we would excrete it and get rid of it. So this is that, kind of like that feedback mechanism system. And then we have tubular secretion. So this is where the formed urine drains from the collecting tubes into the renal pelvis and down each ureter to the bladder. So glomerular filtration. So this is a specific term that we use to talk about the movement of wastes across the glomeruli into that Bowman's capsule. The amount of filtrate formed in all glomeruli of both kidneys per minute is what we call the GFR, which is our glomerular filtration rate. So we don't say glomerular filtration rate in the hospital, we say GFR all the time. That's just how we say it. Our waste, the waste in our body is it's a continuous process being filtered from that glomerulus into that Bowman's capsule. Wastes do not include red blood cells and almost no protein. So if we have red blood cells and protein spilling into our urine, that is a sign that something is going on and we need to investigate further because those are not things that we should be excreting. Normally, our urine consists of water, sodium, chloride, bicarbonate, potassium, urea, creatinine, and uric acid. Amino acids and glucose are typically reabsorbed, not excreted into the urine. Again, if we see them in the urine, it's a signal that there's a problem. We need to do some further investigation. So you'll learn in metabolism next week that sometimes when diabetics have too much glucose in their body, they spill it into their urine, which is a sign of diabetes. So again, just the take home there is that if we do see these things, it's some type of a problem. When we see persistent and elevated proteinuria, so that's high levels of protein in our urine, it can indicate that there has been damage done to that filtration system. Glycosuria, which is glucose in the urine, occurs when the glucose concentration in the blood and the glomerular filtrates exceed the ability of the tubules to absorb the glucose. So glucose is very thick and viscous. So it's only a matter of time before the system can't filter that out anymore. And then it's going to start spilling into your urine. And this is why people who have diabetes usually end up with some type of renal disease because their kidneys can't handle all the high levels of glucose. So tubular resorption. So the glomerular filtrate enters the Bowman's capsule and then it moves through that tubular system of the nephron, and it's either going to be, like we said, reabsorbed. So we're going to take it out of that nephron and put it back into our systemic circulation because we need it for some reason to maintain fluid balance or electrolyte balance. Or if we have too much of it, or we have just enough of it and we don't need it, we're going to go ahead and just excrete it in the urine. So it's going to go one or two ways. Something else we're going to talk about it a little bit more in detail, but that glomerular filtration rate, so that we always look at that as a lab. That tells us how good, it's an indicator of how good our kidneys are functioning. So just like we talked about the creatinine and we talked about the bun, this is something else that we look at as well when we're trying to determine kidney function. All right, so fluid balance is determined by that antidiuretic hormone, ADH. This should sound familiar from homeostasis. So ADH is going to be excreted. It's already too early and I can't talk. ADH is secreted from the body if there's a decrease in blood volume or an increase in serum osmolality, which means that the concentration of the number of particles of a solute in a solution is highly concentrated. So if we're dehydrated, it's going to secrete ADH. As this happens, the distal tubules and the collecting tubules become more permeable in order to increase the amount of water that they can take in and that they can reabsorb back into the blood. As that happens, it's going to increase our blood volume. And if we increase our blood volume, it's also going to increase our urine concentration. If there is excessive water intake, then we know that that ADH secretion is going to be suppressed because we know we have too much water, so that system's not going to work, and it's going to increase the amount of water in the urine. And then we have tubular secretion. So this is formed urine that is going to drain from the collecting tubules into the renal pelvis and down each ureter to the bladder. Potassium and hydrogen ions are going to be excreted from the blood to the tubules in order to help maintain that serum potassium levels and to regulate that acid-base balance. And then the pH level of normal urine is going to be between 4.6 and 8.0. So urine is going to flow from the renal pelvis through the ureter into the bladder. Urine flows in one direction because it's kind of like our bowels. It has that peristaltic action. It just keeps pushing it down. Sometimes you will see reflux of urine. So that's urine that comes backwards. It's a backflow of urine. We see this sometimes when there is an over distended bladder and it can't hold anymore. It has no other place to go but back. That's usually the only time we see that. The nerve centers for urination are situated in the brain and the spinal cord. So keeping that in the back of your mind. I'm so
sorry. Can you post this after? Because there's some slides on here that we don't have access to.
Yes, it's because I couldn't, I changed some of them, but then course points down, so I couldn't get up to.
Okay.
I mean, Brightspace. As soon as Brightspace comes up, I'll put them up there.
Gotcha. Thank you so much. Sorry.
Yep. The nerve centers for urination are situated in the brain and the spinal cord. So sometimes if we have patients that have issues with some kind of brain damage or spinal cord damage, it's understandable why they have neurogenic bladders or they're incontinent at times because they don't have any control. They've lost the nerves that affect the control of urination. So urine helps to get rid of the body's waste products and materials that exceed our bodily needs. So whatever we don't need, our body knows and wants to get rid of it. It's the body's liquid waste product. We also use the words urination, micronutrition, and voiding interchangeably when we talk about going to the bathroom, urinating, all that good stuff. Usually adults can excrete 1 to 2 liters of urine in 24 hours. That's just an estimate. Not everybody puts out that much depending on the health of their kidneys and how much fluid they take in during the day. So we talked about different hormones. So renin will kick in if the blood pressure or circulating volume falls too low. So in the case if we are dehydrated, renin is going to be excreted into the bloodstream. This is going to in turn activate a process called that renin-aldosterone system. Renin-angiotensin-aldosterone mechanism, which is going to help raise our blood pressure. Aldosterone is going to promote sodium and water retention to increase blood volume and further elevate our blood pressure. So we know that water follows sodium. So if our kidneys are holding on to sodium, water is going to follow, and then that's going to help elevate the blood pressure. We know that it makes erythropoietin, so it stimulates the stem cells that are located in our red bone marrow to increase the formation of red blood cells, which is going to contribute to our hematocrit, hemoglobin, and our total red blood cell count. This process is known as erythropoiesis, and erythropoietin is secreted when hypoxia is recognized. So if this is another one of those feedback mechanisms. So if we become hypoxic, or the body thinks that we are hypoxic, it's going to think that we're not getting enough oxygen to the brain. So the first thing the body thinks is our red blood cells carry oxygen, so we must not have enough red blood cells because there's not enough oxygen going to our brain. So it starts making erythropoietin to make more red blood cells so that we can have more oxygen and we can get rid of the hypoxia. We also have ADH, which is antidiuretic hormone, also known as vasopressin. So in response to angiotensin II and to low fluid levels in the body, that posterior pituitary gland is going to secrete ADH. ADH increases the resorption of water by the kidney tubules. The resulting effect is we're going to maintain an adequate circulating blood volume and blood pressure, which means, therefore, we will have homeostasis in our body. And it also stimulates the thirst center in the hypothalamus to let us know that we're thirsty and we need to take in fluids. So this is one of the issues that we see, remember, with our older adults, that mechanism in the hypothalamus that tells us we're thirsty, they don't see that as they get older, or it's very diminished. So this is why they're so easily dehydrated. Then we have ANP, which is that atrionatriuretic peptide. This is going to be secreted by the atria, which is located in our heart. It is, when it's secreted, it's going to increase our kidney filtration and blood flow when blood volume increases. It benefits the heart because it does not make the heart pump as hard. It's important to know how these hormones affect our body, because when we give medications such as antihypertensives that work on the body to decrease the blood pressure, you need to have a good understanding of what's going on in the body. And it's also responsible for vitamin D, which is a fat-soluble organic compound which is synthesized in our skin. We get vitamin D from diet and sunlight. It is not something that our body makes. We get it from diet and sunlight. It's in an inactive form and cannot directly promote absorption. For vitamin D to become metabolically active, conversion must first occur in the liver and then in the kidneys. All right, so the pathway of waste products. So through peristalsis waves, our smooth muscles are going to carry urine drop by drop to the urinary bladder. Your bladder can hold between 300 to 500, sometimes upwards of 1,000 cc's, depending on the individual and how much they've had to drink, and just their genetic build. Urine is going to travel from the renal pelvis into those ureters. The ureters then attach to the kidneys and carry urine from the kidneys down to the urinary bladder for storage until we're ready to empty it. The urinary bladder is located just behind the pubis. The muscles in the bladder walls distend, so it gets wider and wider as it fills with urine, and then it contracts and goes back down as the bladder empties. The bladder can hold about 1,000 cc's max. An involuntary internal sphincter relaxes as it senses the body's voluntary impulse to void. So then it's going to let all the urine out, and then that internal sphincter again will then contract when we're done emptying all the urine out. And to initiate urination or voiding, the detrusor muscle contracts and the external sphincter relaxes. So we talked about how the muscles in the bladder wall distend as it fills up, and then it contracts as it empties. So patients sometimes do not always get all of their, and we're going to talk about this a couple slides down, but they don't always get all of their bladder out, all of their urine out of their bladder. Sometimes a little bit stays in there. We call that a residual. Sometimes that bladder doesn't contract and go back to the size that it should, so it doesn't get all the urine out, and that urine stays in there, leaving them susceptible to urinary tract infections and other things. So the urethra is the tube which urine passes to the outside of the body. In men, the urethra is about 8 inches long, and it passes through the prostate gland and then the length of the penis. In women, the urethra is about 1.5 inches long, and it opens to the outside of the urinary meatus or urinary canal. So remember, in fundamentals, we talked about how women were more likely to develop urinary tract infections, and that's because of their of the way that their urethra is and how short it is compared to men. So the bacteria doesn't have to travel as far in women before it can start an infection. So what should our urine look like? So our color of our urine should be a very light to a light yellow amber most of the time. Usually in the morning, if your kidneys are functioned properly, your urine will be very concentrated, because if you have good, healthy kidneys, you're not peeing all night. Remember, we talked about those older adults who pee all night long because they can't concentrate urine. So they can't hold their urine all night long. So they're never going to go all night without peeing and then have that really dark yellow concentrated urine in the morning. If we are overhydrated, which means we are taking in too much fluid, it's going to be colorless. If you guys have ever just been on a healthy kick and decided to drink a lot of water, you'll know that sometimes when you pee, you can't even tell it's in the toilet because it's completely the same color as the toilet water. If you're dehydrated and you're not drinking enough, you can have very dark yellow, even an orangish brown type of a color to your urine. When we talk about clarity, we want our urine to be clear. So we don't want any kind of sediment. So we don't want any type of pus, any kind of white blood cells in there. We don't want any blood. We don't want to see any red speckles in there. It should always be clear. It shouldn't be, hazy. You should be able to see through it. It should be odorless. Shouldn't have any type of fruity or foul odor to it. The minimum that we want to see our kidneys put out is 30 to 50 cc's an hour. So if you are concerned at the end of your 12-hour shift that your patient has only put out 200 cc's and you don't know if that's enough, well, then you divide that amount by the 50 or the 12 hours, and it'll tell you how much that would account to for an hourly basis. And you need to be at least 30 to 50 cc's. So in the ICU setting, they really measure this every hour to make sure that they're at least getting that 50 cc's an hour. When we talk about specific gravity, so specific gravity is the measurement of our kidneys to be able to concentrate and excrete urine. So if our patients have what we call a low specific gravity, it means that they are having an increased urine output. They're peeing way too much, probably because they're drinking too much. So their specific gravity is going to be low. They're not able to concentrate urine. If they have a high specific gravity, then it's going to be because they have decreased urine output. So they're not drinking enough. You guys need to know what that means. The acidity of the urine works to help control bacteria. That's why we want it to be between 4.5 and 6.5. And then abnormal components, well, we said we could see blood. So you could see speckles of blood, you could see streaks of blood, you could see whole blood clots. Just depends on really what's going on with the patient. If you have a urinary tract infection, you might test positive for pus and white blood cells in the urine. We can see glucose in the urine and protein as well. You can take a look in your book. Table 57-5 talks about the characteristics of a urinalysis. It's on page 1063. All right, we can also do what's called a creatinine clearance test. Spelled wrong, sorry. Creatinine clearance test. So creatinine is broken down constantly. It's constantly occurring. It's breaking down at a constant rate, and then it's excreted by the kidneys. You guys need to know that. That's why it's in bold. You're going to see it on your exam. Creatinine is a substance that results from the breakdown of phosphocreatine, which is an amino acid waste product, which is present. We find it in our muscle tissue. Creatine is filtered by the glomeruli and is excreted at a constant rate by the kidneys. It's constantly happening. We use this test to determine kidney function and creatinine excretion. A client with renal failure would present, normally in his labs, you would see he would have an increased creatinine clearance and a decreased glomerular filtration rate. So if that creatinine clearance is elevated, that means that it's not working like it's supposed to. And then obviously, if that GFR is decreased, that means that we're not filtrating from the body like we should. And you can read more in your book about creatinine clearance. So this is kind of like a little guide that you can see. This is what your urine should look like. So if your urine matches colors 1, 2, or 3, you are considered properly hydrated. You should continue to consume fluids at the recommended, whatever's recommended for you. If your urine color is below the red line, you are dehydrated and at risk for cramping and/or heat illnesses. So, we see that people get dehydrated all the time during the summer because they're not drinking a lot and they're in these, really hot degrees, working outside, doing sports outside, things like that. So you need to drink more water. So it's okay for you to see this when you're emptying your patient's urinal or their little hat in the bathroom to say, your urine is really concentrated. We need you to start drinking more water. So urine is initially a clear yellow liquid with a characteristic odor. It does have some type of odor to it. It shouldn't be particularly foul, and it has a very acidic pH. So the composition of normal urine is about 95% is going to be water, and 5% is waste products, excess minerals that the body doesn't need that it gets rid of, those toxins and certain drug metabolites that the body's not using, hormones, and then certain pigments. So all things that we don't need. So when we are assessing our patients, so we're going to do that physical history. We want to know what their urinary habits are like. So when I ask my patients when was their last bowel movement, they tell me, and then my next question is, do you have any trouble urinating? Any burning or pain when you urinate? No. Do you have any issues with frequency or urgency? So do you all of a sudden have to get up and go? You can't wait. And do you have to go all the time? Are you going like once an hour? Do you have a problem with hesitancy? So maybe you can't start a stream. So you're trying to pee, you feel like you have to pee, but it takes a minute or two for your urine stream to actually start. Do you have dysuria? Dysuria is pain or difficulty voiding. Nocturia is when we get up in the middle of the night to go pee. We want to know if they have any problems with incontinence. So do they dribble on their way to the bathroom? Can they not even make it to the bathroom? Maybe they don't know that they have an urge to go. So do they feel like they have to go and they just can't, it just comes on too fast? Or do they urinate and they're not even aware that they're urinating? Polyuria, so this is, there's a chart in your book that's going to tell you all about these diseases, but I do believe I also put them down here too. So polyuria is peeing and peeing and peeing and peeing and peeing. You can't stop peeing. Oliguria is when we have less than 400 mLs per day output, and then anuria is less than 50 mLs a day. Now, with that being said, patients who are in end-stage renal disease or close to it, some of them don't make urine, so they can can go days at a time without any urine at all, or they might just go 30 or 50 mLs a day. It just depends on the patient and how far into renal disease they are. We want to know if they see any blood in their urine when they urinate, and do they see any pus, any foul odors, and then we want to test them for protein in the urine as well. Sometimes it will look like Coke, like the soda Coke, if they are putting protein in their urine. And then we always want to know what their chief complaint is, if that was their main reason for coming into the hospital. Usually in the hospital, it's because there's some kind of obstruction, or they have like a UTI that has gone to their systemic system and it's caused them to be septic. We also want to look at their abdominal area, especially down by their above the symphysis pubis, right there at the bottom. That's where their bladder sits, right above that. In a patient that is distended, that is not able to release urine, you will notice, you will absolutely be able to tell. It will be very, very distended, and it will be hard to see, and probably in someone who is overweight, of course, but in your smaller patients who don't have a lot of body fat on their belly, it's very obvious, and they will complain of a lot of pain. You can look in your book, figure 57.5 and 57.6 on page 1058 will show you how to palpate the bladder. And then we're always going to run laboratory tests related to these issues. So we're going to be looking at that serum creatinine level. So these will come from protein and muscle breakdown. We want to look at blood urea nitrogen. So that's BUN. We don't really say blood urea nitrogen in the hospital. We just say BUN. BUN this can be elevated when there's a breakdown of protein in the liver that then creates a byproduct of urea nitrogen that is excreted in the kidneys. BUN is also an indicator of hydration and kidney function. Kidney disease, it says in your book that kidney disease is the only condition that increases serum creatinine levels. So that is true to an extent. In the long term, that's what we see, but sometimes if a patient has taken a medicine, that it can cause an increase in their creatinine levels, and we have to discontinue the medication. And then sometimes if the patient is dehydrated as well, we can see that that's the first thing in the primary care setting that we would tell a person if we did their labs and their creatinine came back a little elevated. We would say, you need to increase your drinking, and then we're going to check you next month. Come back in a month. So factors that affect our BUN. So dehydration, if there's any type of an infection, certain antibiotics can affect our creatinine sometimes. Chemotherapy, some of our chemotherapies are extremely hard on our patients' fluids. I mean, on our lung, on their kidneys. So what we have to do is before they get chemo, we have to pump them full of fluids to try and protect their kidneys from the chemo. And then they have to intermittently get fluids between the chemo. And then once it ends, more fluids. Steroid therapy can damage our kidneys, and then reabsorption of blood in the liver can also damage our tissue. And then elevated BUN is also suggestive of kidney disease. So sometimes it's necessary for us to take a urine specimen, depending on what we're looking for. Maybe we want to look at their creatinine and their BUN levels to see if there's any kidney damage. Maybe we want to see if they have white blood cell count or pus or blood in their urine. Maybe they have a UTI. We want to see what's going on. So we can do what's called a routine urinalysis. So this is going to evaluate the waste products that come from the kidney, and it can also detect some type of a variety of different urologic disorders. Nothing special to do for that. They can just go and pee in a cup. Sometimes we need a clean catch or a mid midstream specimen. So normally we like to do, especially if we're doing a pregnancy test, we want the first void of the morning. And we prefer this because it's a more concentrated sample. We want to make sure when we're doing a clean catch or a midstream that it is not contaminated by the skin bacteria. So I put down here at the bottom that the patient will void, and then they're going to discard a small amount of the urine. So they're not going to pee into that cup. They're going to just pee. Once a small amount comes out, they're going to continue. They're going to put that specimen cup underneath of them, and then they're going to continue to void. They're going to stop. They're going to stop voiding once it gets filled, the container. They're going to remove the container, and then they can continue voiding and then discard the last amounts of urine in the bladder. Usually they just do it in the toilet. They pee, they wait for, a second or two for some of that urine to be gone. They put the cup under there and they go, they fill the cup up, and then they finish peeing when they're done. So that first small amount of urine voided helps to flush away any organisms or any bacteria that's around that meatus. If the patient isn't very hygienic or if they just haven't had a chance to really clean well. We can do sterile specimens from an indwelling catheter. So nurses clean the port on the drainage tubing along with an alcohol wipe before drawing a sample from the patient. So let's look at this slide. So this is the nurse. So you can never just draw, if the doctor says I need a urine sample and they have a Foley, you're never going to go in and just take from what's in the bag unless you just put the Foley in. If you just put the Foley in and literally the urine just came out 30 seconds ago, you can unclamp it and fill it into the cup because it hasn't been sitting in the bag. The longer it sits in the bag, the more contaminated it gets and the more the bacteria builds. So it's not going to be a true assessment of actually what's in their urine at that present time. So what we do, and this will make sense when you see the Foleys this weekend if you've never seen one, there's 2 ports on the Foley. So you never, ever, ever take that red tape off. So that red tape there is always, if you guys can see that red tape is always going to stay there. This little blue port underneath of it, you are going to clean that little port off because it doesn't have a cap. Really, really good with alcohol. What I like to do is before I connect my syringe here to pull back urine, I like to fold it in half. I kind of milk the tube a little bit because see right here, this urine that's sitting here, I don't know how long that's been sitting in there. Sometimes it could sit in there for an hour or more until the patient pees again and pushes it out. So what I do is closest to that little blue area right there, I fold the tube in half. So that way I know that nothing down from the tube is going to come back. And then you can insert your usually it's a 10 cc or 10 ml flush, empty flush container that we use. We pull back urine and we do that until we get, a half of a container or enough that you would be able to test. So never, ever, ever, ever disconnect the red tubing. Always clean it off with alcohol. All right, let me see, where was I? Okay. Sometimes we can get a urinary specimen from a urinary diversion. So just like our patients who had colostomies, we can have a urostomy. So they can have a urinary drainage bag where their urine drains into the bag. That would be okay. If they needed a sample, I would empty the bag from whatever was in there right then and there, and then I would wait for them to pee again and then go in and grab it, and have them let you know, hey, I just put a sample in here, and then you go right away and you get it. That would be the equivalent of them peeing, leaving it in the cup for you, and you going in and get it. We can do what's called a 24-hour urine measurement, and this is important. You guys are going to be tested on this. So normally when we do a 24-hour urine specimen, it's because we are looking at creatinine clearance. Sometimes we want to know the levels of the urea nitrogen in the body. We can be looking for sodium levels, calcium levels, different proteins or catecholamines. There's a variety of different things we can test for. If you have a patient who is getting a 24-hour urine specimen, the first thing you do is you get a container. It's a big blue, it looks like, brown, looks like a big brown jug. It's dark, has a label on it. You're going to put your patient's name. You're going to put your initials. You're going to put the date and the time that you started with the first urine. So you get everything ready. Then when the patient urinates, you pour it in there, and that's when you date and time it. So you're going to collect urine in that container. Every time they pee, you're going to pour it in that container, and you're going to collect it for 24 hours. But it has to be on ice, because if not, it's going to become contaminated because the urine is going to be sitting there. So we need to keep it cold. So usually we get one of those big pink like basins that we give patients that are going to vomit. We fill that with ice, and then we put that big container right in there. And then you have to monitor that you have to keep replacing that ice as it starts to melt. Okay, so we have on there the collection bottle is labeled, and then you want to have separate receptacles for voiding and defecation. So if your patient is a guy and he's using a urinal, that's great. No stool is going to get stuck in the urinal. God willing, unless he's confused. I guess that could happen, but it probably shouldn't any other time. For females, if they're going into the bathroom, you would want to, those little white hats that we put in the bottom of the toilet, you would want to put 2 in the toilet, and 2 will fit. So one would be, you would say, if you're going to pee, please pee here. And then if you have to have a stool sample, please put your stool in the back. If it combines, we cannot use that sample. You would have to discard it and wait for the next sample. We can never combine, because it's going to show that there's bacteria in there because there's stool mixed with it. So keep it on ice, make sure it's date, timed, and initialed, and then make sure you have separate receptacles for defecation and voiding. So this is how you get your sample from the Foley. This is the nurse's hat right here where my mouse is. 2 of those will fit in a toilet. They're really nice because they have the measurements inside. So when they pee and fill it up, you know how much is in there. This little cup here would be your urine sample. This is your graduated cylinder. If I have a patient that has a Foley, I'm emptying that Foley into this graduated cylinder. I use it to measure it, look at the color, the clarity, and then I dump it in the toilet. This is a urinal, and then these 2 are bedpans. So this here is called a fractured bedpan. This is I use this for our real little old ladies or really tiny people, because this big honking bedpan here will really, really hurt a small person's back. So I like to use this little one for littler people. This is a great picture. This shows you the sizes that your bladder should be. So let's zoom in here. So this is the size of your bladder normally when it's empty, no urine in it at all. Then as it starts to fill, it's going to become distended, right? So it's going to get bigger. This is grossly distended, and this is a bad thing. So your bladder cannot continue. It's like a balloon. Eventually it's going to pop. And that's a really bad sign. A patient can die if that happens. So you want to prevent the rupture of someone's bladder. So this is why it's so important as nurses that you are always calculating those strict I's and O's. You want, even if the doctor doesn't put in orders for you, because if they're eating and drinking and they're taking fluids in, you have to make sure that what's going in is coming out. If it's not happening, there's a problem developing. So that's why you always implement strict I's and O's. You are responsible for them, even if you delegate them to your tech. It is your responsibility at the end of the day to know how much your patient has went to the bathroom and what their urine looks like. So you want to avoid this grossly distended. This patient that has this bladder would be probably crying and in a lot of pain. All right. All right, so some issues that we can see with urinary elimination. So we can have urinary frequency. We talked about some of these: urgency, dysuria, nocturia, enuresis, polyuria, incontinence, urinary suppression. We can deal with oliguria and anuria, which is the very little output of urine. I think oliguria is 400 in a day, anuria is 50 in a day. If our patients are experiencing oliguria, when we're giving a report, or how we refer to them, is we say that they're anuric or they're oliguric. That's what we say. That's how our nursing words. And then sometimes we can have urinary retention, which we know is a problem. So you can have distension, you can have retention overflow, which happens when you have too much urine in there and it backflows. And then you can just have temporary urinary retention. Sometimes we see it very common if a patient comes from surgery because everything goes to sleep. So it takes a while for everything to work again. Our bowels, our kidneys, it's just a slow process. And then sometimes if a patient has had a Foley in, we usually give them about 8 hours. We'd like to see them pee within 8 hours. If they don't pee within 8 hours of having a Foley, then we need to do a bladder scan. So depending on what issues our patient is presenting with, there are different renal diagnostic procedures that we could do. So we could do certain x-rays. So we can do a KUB, which is short for kidney, ureter, and bladder. Some people call it a flat plate. I probably heard that once or twice. They don't really say that anymore. This is nothing other than an x-ray to examine your kidneys, your ureters, and your bladder. We can do the CT scan or the MRI, which is going to give you that three-dimensional imaging, so much better pictures of the urinary system. We can look for kidney size. We can look for kidney issues such as obstruction, cysts, or even masses. We can do ultrasound, so we can do an ultrasound to measure the size of the kidneys. It'll give us a very clear picture of the ureters, the bladder. It can help identify if there's any masses in there, any cysts, any renal calculi, so kidney stones, and then any type of obstruction of the lower urinary tract. And then we can do something a little bit more invasive. So we have something called a cystoscopy or a cystourethrourethropy. So these would be used if we thought there was some type of abnormality or an occlusion. So if we think there's something going on with the bladder wall, if we think there's tumors or occlusions in the ureter or the urethra somewhere, we would want to go in with a little scope and look inside the ureter or in the bladder to see what's going on. Typically, if patients are going to have this procedure, we do want them to be NPO after midnight. And then post-procedure, we want to, when they come back, we want to make sure that they can resume with urinary output. So again, probably post-procedure, I would say 6 hours is maybe when you would want to give them to pee. You probably don't want to wait the whole 8 hours like you do with a Foley. Make sure that they pee. How much are they peeing? And then what does it look like? So obviously, if they've had a cystoscopy, they're famous for causing trauma just from going in there. You might have a little bit of blood in there, so their urine can be pink tinged. I've seen sometimes where it can be bright red at first, but then as they start to pee more, it lessens and lessens and lessens. You want to encourage them to drink as much as possible because we want to increase their urine output to get all of that blood or whatever else is in there out. And then to reduce any burning sensation with urination, which is completely common if you've had any kind of scope that's going in there, even with a Foley. It causes a little bit of a trauma. And it's normal for patients to say that it burns when they pee, but it should subside. So a cystoscopy is a direct visual examination of the inside of the urethra and the bladder using an instrument called a cystoscope. It identifies the cause of painless hematuria, urinary incontinence, or what's causing urinary retention. We can do a renal angiogram, which is going to look at all the arteries to the kidneys and look at that blood supply that's going to the kidneys to make sure that they're getting properly perfused. A catheter is going to be passed through the femoral artery into the aorta, and then it's going to go to the level of the venal vessels, and then it's going to take a picture of all the vessels in there to see if there's any blockages. This requires a contrast dye medium to be injected in the catheter which will show up on the x-ray as signs of problems. So with these patients, we want to definitely make sure when they get back that we are monitoring these patients for bleeding because they're going through that femoral artery. So they should have a pressure dressing there. They usually have to lie flat the time. Each facility is different. It's usually 2 hours. They have to lie flat. You're going to monitor for bleeding, and then you're going to monitor blood pressure, make sure there's no internal bleeding anywhere. And then you want to make sure that they're drinking lots of fluids to get rid of all that contrast dye. And patients that already have kidney issues may not always be a candidate for this. If they do have to do this and they have, like say they have end-stage renal disease, they will give them fluids before and fluids after to help protect their kidneys. And sometimes they can't get it done at all because even the fluid the kidneys can't handle. We can do a pyelography, which is an intravenous pyelography, which is a study to evaluate the structures and the functions of our kidneys, our ureters, and our bladder. Looks at everything. We would give this to a patient only if they were able to excrete this dye. Like again, if they had elevated creatinine and bun levels, depending on what their history is, we might be able to give them fluids before and after, or we might have to wait for the creatinine to come down in order for us to be able to do this. Sometimes I've actually seen it where I had a patient one time who was in end-stage renal disease and they really needed to do it. So they did it, and then they took them to dialysis right after and did dialysis to remove it off of them. Or they have something called a retrograde pyelography. This is better than just a pyelography. It gives you a better visualization of the ureter and that renal pelvis, if you think the main concern of the problem is in those two areas. And if we had to do that, they would do that during the same time they were doing a cystoscopy. But doing a retrograde pyelography carries a higher risk, because it's easier to develop a UTI, which could then turn the patient septic. So you guys can read on page 1061 under nursing guidelines for caring for the patient undergoing intravenous or retrograde pyelography. There's a lot of good information in there. So some nursing diagnosis for a patient undergoing a cystoscopy, urinary retention related to edema in urethra obstructing flow of urine. So remember I said when they go in there, it is a risk that they can cause some type of trauma. It's a very little area, and that machine is going in and it's coming out and it's moving around, and it's a very small area. So it's easy for trauma to occur, and then you get edema. And then if you get swelling in that area, well, no pee is going to be able to come out. Risk for infection, it's an invasive procedure. We're putting something directly inside the patient. And then acute pain, dysuria related to an inflammatory process in the bladder. So a cystogram will evaluate those bladder structure abnormalities. It's going to show through the filling of a contrast dye, and then a subsequent series of radiograph x-rays. We can do something called avoiding cystorethrography, which is where the patient is voiding, and at the same time that they're voiding, they're taking a very rapid series of x-rays. So it shows the urine moving through the bladder into the ureters, how fast it's going, and if there's any kind of obstructions or any kind of issues going on in there. If a patient has a UTI, we would not want to do this in them. We don't want to put this, we don't want to put them through that because they're going to have trouble voiding. So it's contraindicated in a UTI. You can do different neurodynamic studies that evaluate the bladder. It can determine compromised renal function. It can assess the cause of a reduced urinary flow. So if patients come in and say, my flow isn't as strong as it was, especially with men, we see this sometimes with tumors. We see it with if their prostate is inflamed. So we could go in there and take a look at things. If they complain of urinary retention or incontinence, because we always want to know what's causing the issue. We can't fix these problems unless we know what's causing them. We can do a uroflowmetry, which determines the flow rate. So this is how well their urine flows from the bladder through the ureters and out of the body. And then we could do something called a cystometrography, which is going to evaluate the tone of the bladder. So how well it contracts and how well it relaxes. And then older adults do lose that bladder tone as they get older, which is a common finding in them. Sometimes we need to do a biopsy. So normally we do it in most cases, if we are diagnosing cancer. Sometimes we do it for prostatic enlargement to get a good indicator of how healthy the tissue is. We can do it to diagnose and then monitor the progression of kidney disease or renal disease. And then we can also do it to evaluate if a patient is who's had a renal transplant rejection. So we want to know if their body is rejecting the kidney, we would go in and do a biopsy. So we could do a needle biopsy, a fine needle biopsy, or an open biopsy. So a needle biopsy is where renal tissue is removed through a needle. Very simple. We go into the kidney, we take our tissue, we come back out. Fine needle is where it's guided. So the needle goes in, it's a smaller needle, and it's guided through fluoroscopy. And then an open biopsy, it's where we make a small incision into, this is obviously more invasive, we make a small incision into the flank area and we go through to the kidney and we take a biopsy. So pre-procedure, obviously these patients are going to be under general anesthesia, so we want to make sure they are NPO 4 to 6 hours prior. We also want to take and review their coagulation studies. We want to look at their PT and their INR. We want to look at their red blood cell count. Also, we want to look at their platelets. So our platelets tell us if the patient can, clot or not. Because we're taking a biopsy, there's always the threat of bleeding that can continue and the patient could bleed to death. So we really need to know what their coagulation studies show. And then post-procedure, the patient is usually on bed rest. Again, it depends on, usually it's just a hospital policy. Sometimes it's an hour flat, sometimes it's 2 hours. When they come back to us, we are going to be monitoring that dressing that's on their back to see, sometimes it's a Band-Aid. If they have to do an open biopsy, there's going to be probably a gauze and some tegaderm on there. So we want to monitor that dressing for active bleeding, signs of hemorrhage. So how can we observe for signs of hemorrhage if we can't see the blood?
The urinalysis.
Well, a urinalysis might show blood, but we're concerned that they're hemorrhaging. They're losing a lot of blood. What's going to be the first place that we see that?
You might see the
signs.
And
Is it their level of consciousness?
Could be their level.
Signs?
Vital
those pulse
signs.
might be thready.
Vital signs, yes. So we're going to see it in their vital signs. Their blood pressure is going to be low. Their heart rate's going to be up. Yes, vital signs. Sometimes you want to observe for any kind of severe pain in the back, shoulders, and the abdomen. Some mild discomfort is common, but it shouldn't be any type of severe pain. And then obviously we're going to look at those vital signs for hypotension and tachycardia. We want to assess the dressing frequently. And by frequently, we mean during your shift. If they just had it done, probably I would go in every 2 hours and make sure that he's not bleeding. Even more frequently if there was blood on there. Assess vital signs. Usually when they come back to the floor, we get a set right away, and then we do them every 4 hours twice. And then they can go back to every 8 hours again. We want to evaluate the type and severity of their pain. We want to make sure that they have good good fluid intake. And we want to observe for any problems with voiding, if they have any cloudy or foul smelling urine, and if they are complaining of urgency or frequency. And then obviously if you are concerned of any systemic infection or urinary tract infection or bleeding or hemorrhaging, those would be causes to notify the physician right away and let them know. So how much we eliminate through our urine is going to depend on how much we take in. So if we don't take in a lot of fluid throughout the day, well, then we're not going to pee a lot through the day. And it also is going to depend on how efficient our kidneys are. So if our kidneys are working good, it's going to be appropriate. It's going to be appropriate when compared to what we take in. If it's not, if our kidney efficiency isn't great, then we may not put out as much as we take in. And then we have a whole nother set of problems. So we do have, it's not always going to be 100. Like if you give them 1,000, they're not always going to have 1,000. We lose some of our fluid through respiration, perspiration. So it's very common that you give them 1,000 and they only put out 300. That's only a difference of 200. It also depends on our salt intake, because if we eat processed foods and eat something that's really salty, well, salt's going to cause us to hold on to water. So we're not going to pee as much. And sometimes we always have fluid involved in our feces, but if we have diarrhea, then we would be putting out more fluid. We could be overhydrated, so we could have edema. So too much fluid, so that's an excess of body fluid that collects in the tissues. And then we can have dehydration, which is deficiency in body fluids. And this should be a refresher from homeostasis. Oh God, I'm sorry. All right, so what types of effects do we see on the urinary system with aging? So the kidney size and the function of our kidneys is going to decrease as we get older. The blood flow adaptability is going to decrease, especially during a hypotensive or a hypertensive crisis. Hold on, someone's trying to get in.
Sophia.
Okay. Kidney injuries can occur more easily because of the contrast dyes and medication due to that decreased kidney size, decreased blood flow, and that decreased GFR. So it's more easy for us to cause injuries to the kidneys. Tubular changes can cause urgency and nocturnal polyuria. So that's where we're going to the bathroom very, very frequently and all night long. As we get older, the urinary sphincter muscle becomes weak, and a shorter urethra in women cause incontinence and an increased risk of those urinary tract infections. With men, we see an enlarged prostate in men, which can cause urinary tract retention and infection. And so that prostate swells up around their ureter, and then it makes it really hard for urine to get out. So they have a slower stream. We have that lessened ability to concentrate and form urine because we're going to the bathroom all night long. We see a decrease in the rate of filtration, excretion, and reabsorption. We do see a rise in our BUN, our creatinine, and our uric acid. So as we get older, these things do tend to just trend upward for no other reason, just in the fact that we are getting older. Not huge numbers, but slowly, in slow increments. Decreased capacity of the bladder. So our bladder can't hold as much. The muscle doesn't work as well, it doesn't contract, so now we're having issues of having to go all the time because our bladder can't hold 600 or 700 or 1,000 like it used to. It can only hold 200. Loss of muscle tone, which means it can't even hold that 200, it's just going to keep coming out. And then we're going to have issues with incontinency. Urinary retention and stasis, this is where we hold on to our urine and it won't excrete from our body. And these are all going to increase the likelihood of developing a UTI because that urine, anytime that urine is retained and it's stayed in the bladder like that and it's sitting still, it's at an increased risk for developing bacteria. Sometimes they might have what's called residual urine, so they may not completely empty their bladder. So if we wanted to see if a patient had residual urine, we would do a bladder scan and see how much urine was in their bladder. Then we would have the patient sit on the bedside commode or the toilet and urinate. After they urinate, we're going to measure how much they urinate and we're going to compare it to what the bladder scan was. So if the bladder scan was 600, the patient urinated 300, there's still another 300 there. So now we want to bladder scan them again and look at that post-void residual. So this is the residual urine that's going to be left in the bladder post-void. So if it said 250, well, then that would make sense. Sometimes with bladder scanners, they can be off by like 75 or 100. It just depends. Like it's kind of like your blood pressure. You can do a reading 3 or 4 times and get a number slightly off, not grossly off. Like you wouldn't get 84 the first time and 600 the second, but you could get 84 the first time, 127 the next time. They can be a little bit off. but that residual urine is what's left in the bladder after they urinate. So if your doctor says, I need you to do a bladder scan and a post-void residual, you're going to bladder scan the patient before you have them pee. Then they're going to pee and you're going to measure that pee, and then you're going to bladder scan them again to see what's left. And that's going to be your post-void residual. With aging, we see a frequency in the urge to void, that retention of urine, and an increased amount of bladder infections. And then we see sexual dysfunction and urine or bladder prolapse is very, very common in older adults. All right, so nursing diagnoses for the urinary system for aging. We have situational low self-esteem related to inability to control or pass urine. Social isolation related to a disabling condition. So patients that suffer, are older patients that suffer from urinary issues like this, where they have stress incontinence or just incontinence all the time, they are known to have social isolation because they're embarrassed. So they'll stay in their rooms, they won't, or if they do come out, they don't stay out very long because they know that they're going to urinate on themselves in a couple minutes, or maybe it's going to be a large amount and their pad, that their protective pad that they have doesn't control the amount that they're urinating. They're afraid of wetting their clothes. It's very, very, very upsetting for those people. So it's very common for them to suffer from social isolation. Functional urinary incontinence related to impaired vision, impaired cognition, neuromuscular limitations, and altered environmental factors. So we do have medications that can definitely affect the color of our urine. So you guys need to know that. So when you see these in the clinical setting, you can try and have an idea of what's causing the color. So if we're giving a patient anticoagulants, it can turn their urine red because they're passing blood in it. So that's pretty common. So this right here, this very first one on the right, that is a patient that has blood in their urine. If they are on diuretics and they're peeing all the time, well, their urine's not going to be as concentrated. So it's probably going to be this pale yellow. So all the way over here on the left, this very first vial right here, that is a good example of pale yellow. If we give our patients Peridium, so Peridium helps with UTIs, with that burning and spasming that they have, we give them Peridium and it relaxes everything in there and takes the pain away, but that causes their urine to be orange. And I mean, really, really orange to red, very similar to what this first one looks like. Some patients take Elavil. This can cause their urine to be green or a bluish green. So this middle picture right here is what their urine would look like. And then levodopa, very, very common for our patients that are on levodopa for their urine to look this brown black color right here. So it's good that you recognize this so that you can do a little bit of a further investigation and see, are they on anticoagulants? Are they on this type of medication? And if they're not, then that's a signal that you probably need to look at other issues. Plus, you want to think about when you're giving these medications to these patients, this is a good opportunity for you to educate them because you want them to know what to expect so that they stay compliant with their medication. Because if they pee and it's that awful color, the first thing that they want to do is stop taking it because they think it's not normal. All right, so diuretics, we know that diuretics prevent the reabsorption of water and certain electrolytes in the tubule. So it helps us get rid of all the excess water that we have, so we can't reabsorb it. We have cholinergic medications which stimulate the contraction of that detrusor muscle and they produce urine. And then we have certain analgesics and tranquilizers which suppress our CNS system and they diminish the effectiveness of the neural reflex. So whenever we suppress our CNS system, everything is going to be suppressed. GI function, GU function, breathing, everything is going to be affected. All right, so renal calculi, also known as kidney stones, and also urolithiasis. So this is a condition of stones or calculi in the urinary tract. Most of the calculi that we find are going to be composed of calcium phosphate or calcium oxalate, but they can also contain other things like cysteine, uric acid is another thing that we see, and struvite. These can occur in our kidney or our bladder. And these stones can be very, very smooth, just like a nice smooth rock, or they can be jagged, and they can be staghorn shaped. So when all three of them can cause a very uncomfortable pain for our patients, even the smooth ones if they're big. So they may be smooth, they may not have any jagged edge to them or be irregularly shaped, but they're huge. So when they try and go through the kidney and the other areas, it causes a lot of pain. When we talk about size, they can be the size of a piece of sand to the size of a marble, which is, and the one that is a piece of sand can be extremely painful as well. Calculi, as they're moving through, they traumatize the walls of the urinary tract and they irritate that cellular lining. They cause pain, and contractions of the ureter develop as they are trying to pass the stone along. So when they're going through the urinary tract, that's where you're getting them violent contractions trying to get that stone to pass, and that's where all that pain is. So patients that have renal calculi or kidney stones will complain of severe flank pain that radiates to the inner aspect of the thigh. And for the man, they're going to complain that it's to the testicle or the tip of the penis. This is bolded for a certain reason. You guys need to know it, okay? It's going to be on your test. So severe flank pain radiates to the inner aspect of the thigh, or for men, they might complain that it's radiating to the testicle or the tip of the penis. These patients that have kidney stones, I've seen some patients that have them and they don't require any pain medication. Those patients have been few and far between in my experience. Most of these patients, I've seen them, they are crying on the floor in agonizing pain, and they don't need Tylenol or Motrin. They need like Dilaudid or morphine or something like that. They are in a lot of pain. Most clients can expel calculi without invasive procedures, so eventually it will just pass on its own. What we normally do is, if we think a patient's coming in with a kidney stone, we screen their urine. So we go to every floor in the hospital, usually has them. It looks like a little funnel, but it has very small, it's a screen with very small holes, so nothing can get through except for the urine. And then we dump our urine in there each time they go. So we tell them that they can't pee in the toilet, they need to pee in the hat or the urinal. We'll drain it. And then after we drain the urine, then we look in there to see if there is any type of a kidney stone. Factors that influence whether or not a patient will be able to pass that stone spontaneously or not are going to include what the composition of. So what is it made of, first of all? Some things like uric acid, sometimes they don't always pass easily. How big it is and the location, where it is. So what would we do medically? We would vigorously hydrate them. We want them to keep peeing to get rid of that kidney stone. So we give them a lot of IV fluids, probably like 150 to 200 mLs an hour. We're going to give analgesics because they are going to be in a lot of pain. Sometimes we'll give them antibiotics because we don't want them to develop an infection. And then we can also give certain medications that just have the sole purpose of trying to dissolve the calculi. If those medical management interventions do not work, then we have to look at possible surgical management. So we can do something called an ESWL, which is an extracorporeal shock wave lithotripsy, which is where they go in basically and they do like a lot of waves on the kidney or wherever the kidney stone is to try and shake it and break it apart into pieces so that the patient can easily pass the small pieces. Sometimes that's not an option. So we do what's called a urethral stent. We'll go into the ureter and we will put in a stent that widens that area up so the stone can come through. We can also do a percutaneous nephrolithotomy or a nephrectomy. So a nephrectomy would be a removal of one or both kidneys, or we could go in and put a nephrostomy tube in. So a nephrostomy tube would go right into the kidney through the back, depending on where that blockage is, and then the urine would come out of that area until the stone passes, or if they have to do another procedure. It really just depends on what's going on with the patient, which route they choose. If you have a patient that has a nephrostomy, you want to be very careful because it's usually just, this tube is just ever so slightly stitched to their skin. And it usually comes back to you from surgery with a dressing over top of it, except for this little circle in the middle where this little baby tube is coming out. That dressing needs to be changed daily. It's a dressing. On Saturday, I was at the hospital and I took care of a patient who had a nephrostomy, and his dressing hadn't been changed since June 27th, because that was the date and time on it. And the day that I worked was 7/2. So that was an entire week that every other nurse 2 times a day looked at that dressing and didn't bother to change it. So when I took it off, it was covered in green and brown pus, and it was red. So there was definitely an infection starting to brew. So then the patient ended up on an antibiotic. So you need to make sure you're changing that dressing, because how are you going to tell if that site, I mean, we went in there and made an incision in that skin. So now we know there's a risk for infection. So you have to be able to visualize that site. Make sure you change the dressing. Make sure you're very careful when you handle that tube, because it can pop out. And then you want to make sure the tube will be connected to a drainage bag and a drainage tube, usually that has a stopcock. So you want to be extra careful when you're repositioning, especially if it's a patient who really can't move themselves around. You want to make sure that they're not laying on that bag and that that stopcock is not digging into their skin, because it can cause skin breakdown. You want to make sure that you're looking at how much is coming out, assessing the color, how much, the smell, and then you should be emptying it probably every 4 hours. Okay, let's see. Urinary tract infections. So UTIs are the second most common type of infection in the body, and they are the leading cause of systemic infections in older adults. What is the biggest symptom that you see in patients that come into the emergency room that could have a UTI? What do they usually present with?
Confusion.
Very good, confusion. You and I would not present with that, okay? Younger people. But those older adults, that's usually what they present with. So a urinary tract infection is an infection of the urinary system. Usually it is caused by E. coli, which is the most common bacteria. Why? Because in women, we are the area where our urethra and our anus is so close. So it's very, very easy for that E. coli that we find in stool to get into that area. It's found in our GI tract and is the most causal organism. We can develop something called urethritis, which is inflammation of the urethra. We can also develop cystitis, which is inflammation of the bladder. And we can also develop nephritis or pyelonephritis, which is inflammation of the kidneys and the renal pelvis. So what usually happens is if you have a UTI that goes untreated, it's going to start moving. The infection is going to start moving up. So it's going to go from the ureters into the bladder, and then it's going to go from the bladder into the kidneys. That's what happens when you have a UTI that is not caught in time and treated. So some expected findings. So your patients may report of lower back or lower abdominal discomfort or tenderness over the areas where their back is. So we say that area, that flank. Flank pain is what they report. They may have urinary frequency and urgency, but without any urine. So they are going to feel like they have to go to the bathroom so bad every 10 minutes, but then when they start to go, they'll get like a bad grabbing feeling that makes them feel like they can't pee. And then sometimes if it's a really bad UTI, they will just pee all blood. They can suffer from dysuria, bladder cramping, and spasms. So how do we treat a urinary tract infection? Usually all the time. We give antibiotics to kill the bacteria and inhibit any more bacterial growth. So what we use mostly is macrobid. Macrobid is right now it is the drug of choice. We can also use Cipro, followed by Bactrim and Levaquin. That might change a little if you're giving IV antibiotics compared to PO pills. If you're hospitalized for it, you're going to be getting IV antibiotics, and then they will switch you over to oral to send you home. Complications of an untreated UTI can be chronic kidney disease, urosepsis, septic shock, and then, of course, death. All right, urinary retention. So urinary retention can be acute, or it can be chronic, or it can just be residual urine, which means that you are urinating, but you leave some urine behind. So acute retention, we usually see after a patient has general anesthesia, everything goes to sleep. Sometimes we see it with certain medications like atropine or phenothiazine. It's pretty common to have acute retention, but then after the medicine gets past the half-life and it starts to wear out of the system, then that usually resolves. Chronic retention is what we see in patients who have prostate enlargement. So the prostate is too large and the urine can't get through, or these patients who have neurologic disorders. So an example would be like a neurogenic bladder. So this is a bladder that does not receive an adequate amount of nerve stimulations. So doesn't mean that these people are incontinent of urine. It just means that they don't know when they have to go. Let's see. So assessment findings for acute. So usually the patient cannot void at all. They'll feel like they have to go. Sometimes they won't feel like they have to go at all. They'll sit. For men, we can try and do different positions for them. So men always pee better standing up. It is very, very hard for them to pee sitting in bed. It's just not anatomically correct. It doesn't work for them. Some people can do it, but it's not ideal. Same thing with your women patients. If you're having them on a bedpan and they feel like they can't go, use gravity. Gravity is your friend. It will help simulate, get everything moving, try and get them up to the bedside commode. Even if they can't walk into the bathroom, get a bedside commode there, do that turn pivot. Patients may complain of an urgent need to void. They may have that distended bladder that we talked about. They can also complain of severe lower abdominal pain, and they'll say that they feel like their abdomen is just full, like they're going to explode. In this situation, these would require immediate catheterization. So if we know that the patient's not peeing, we're not documenting good I's and O's. We've been watching them. It's getting, towards the end of your shift, you're going to bladder scan them, see what's going on. And then usually there is a guideline. So you'll call the doctor and say, hey, Mrs. Jones hasn't had any urine output since 8 o'clock this morning. She only had 100 overnight. And he'll say, okay, bladder scan and straight cath for anything over 250. 250 is usually the magic number. If you bladder scan them and they're only at 150, then you have to look at what's going on. So are they not eating? Were they NPO? Are they feeling nauseous? Are they not on any fluids? So what isn't going in really can't come out. So you kind of have to assess the whole situation. And then you would go back in like an hour and reassess again and see if that amount is, increasing. If you scan them and they have 300, 500, then you need to definitely straight cath them. All right, chronic urinary retention. So clients may be able to void, but they don't empty out their bladder completely. So they have that residual retention, or they have a large residual volume, just depends. Patients may have signs of bladder infection and dribbling of urine. So they require permanent drainage. So for men, who have BPH, they may have a permanent, you could have a urostomy, you could have a permanent indwelling catheter for a woman, not always ideal because you're at a risk for developing an infection, or you can have a suprapubic cath, which goes right in the suprapubic area. It goes in through the outside of the skin, and that is connected to a drainage bag. That again is permanent, but it does need to be changed. How often it's changed is depends on the urologist and the situation of the patient. Usually if they come into the hospital and they don't know when it's changed, we'll change it right then and there. Urology will come up, pull the old one out, stick a new one in. It's very simple. It's not something that I've ever done, but some nurses are trained to do it. Diagnostic findings. So we would probably want to look at a urinalysis. We want to see if they have any bacteria in there, what's going on. We're going to definitely catheterize them because we want to get that urine out. We don't want to rupture their bladder. And we might also do an ultrasound to see what's causing this, what's causing them to not be able to void. Was there a mass in there, some kind of edema, what's happening? And then of course, we will also use a bladder scan to determine how much urine is in the bladder. So there's also medical and surgical management we can do. So we can do immediate catheterization. So we can do a straight cath where we just go in. It looks like a Foley, but it's not connected to the drainage bag and it fills up in a little container. And then you do that intermittently. If it's a patient, if I've had a patient that I've had to do that 2 or 3 times to, or 2 times, and they want me to do it again, then my request is going to be that we put in a Foley at least for the next 24 hours, because every time you go in and you straight cath that patient, you are running the risk of bringing in some type of bacteria and giving them a UTI. So that is something I will advocate for the patient for. Sometimes they're very adamant and they say, no, we're going to keep doing it. And all you can do is just ask and then document it in the computer. Sometimes you might have to put in that Foley. Sometimes they might need to go in and put that stent in to open that area up so the urine can flow through. And then we, again, might do those nephrostomy tubes that drain for an undetermined amount of time. It just depends on what the problem is and what they plan on doing, how long those nephrostomies are going to stay. If it's chronic, we might have that permanent drainage for by an indwelling catheter. Like I said, there's an increased risk of infection. So really, we should have a suprapubic catheter if that's possible. They might have that urostomy. And then intermittent catheterization. This is something that a lot of competent people will do on their own at home. But this is not something that would be appropriate for someone who has cognitive disabilities or any kind of mobility issues, like, you know, who can't use their hands, who are grossly obese, they can't do things, reach their anatomy, things like that. So it would have to be for the appropriate patient. So sometimes we see temporary retention after we receive anesthesia and when using a bedpan. So some of that is just mental. Some people see a bedpan, they're like, nope, can't do it. It's embarrassing. It's mind over matter sometimes it's not, especially for men. Men, like I said, it's very hard for them to pee laying down. As far as nursing care for the patient who has urinary retention, we want to report if the urinary retention continues. So we're going to be monitoring our patient. We're going to be checking their abdomen to see if their bladder becomes distended and if the patient starts to complain of being uncomfortable. We want to make sure we are accurately measuring that intake and output all throughout the day. Palpate the abdomen to see if it's distended, promote complete urination. So having those patients standing up to use the urinal, having them do that turn pivot and get on the bedside commode next to the bed. And then we want to monitor their voiding pattern. So how often do they go? Well, maybe you have a patient who has end-stage renal disease and it's 6 o'clock at night, you're like, oh my God, he hasn't had any urine output all day. Well, maybe he doesn't make urine. Okay, so what is their normal voiding pattern? And then bladder scan. We know that that is going to be a pretty accurate measurement of any urine that is inside their bladder. Usually it comes with an order for a bladder scan, catheter, and a post-void residual. So they want to know, okay, there's something going on with the patient. So we're going to scan them. We want to see how much is in there. Then we want to take the urine out, either by them doing it on their own or straight cathing them. And then we want to know how much is left after they void. Ultimately, the goal is for the patient to safely empty the bladder and prevent infection to the urinary tract. So when you have an order for all these things like bladder scan, straight cath, and post-void residual, there's always a spot in your documentation where you would want to post that. And that's exactly what you would put. It'll have a spot for your bladder scan, so how much was in there when you scan them. Then it'll have an amount for how much they peed, and then they'll have an amount for that post-void residual, and you would just type those numbers in. All right, so benign prostatic hyperplasia, this is something that we see with men. It is an inward encroachment of the prostate gland. So you can see in the picture here, so here's the bladder, here's the prostate that surrounds both sides of the urethra. This is the normal prostate. Here, this prostate is enlarged and it's compromising that urethra. So this is your patient who has trouble starting a stream, trouble urinating, because there's not a lot of room for the urine to get through. So BPH. So this is when the number of cells increase in a structure. We call that hyperplasia. If the cells are non-malignant, it's benign. So this is benign prostatic hyperplasia. So the prostate gland is going to contain more than the usual number of normal cells. This elevated number is going to interfere with the emptying of the bladder. So some of the signs and symptoms you will see: urinary frequency, urgency, hesitancy, or incontinence. You also may see incomplete emptying of the bladder. So they're going to have that residual urine left in their bladder. They might dribble a little bit after they void. They might suffer from nocturia. They may report that they have a diminished urine stream, that it just trickles out. They may strain with urination because they're trying to push the urine through. It doesn't help, but they think that it will. And then sometimes, if left untreated for long enough, you may actually see some blood. So hematuria, blood in the urine. So in order to diagnose BPH, the doctor would do a digital rectal exam and palpate the prostate gland through the rectum, and it would reveal an enlarged and an elastic gland. So for medical interventions, we could give certain medications. So we could give medications that cause that delay the release of DHT. DHT is a hormone that causes the unwanted growth of the prostate. We can also give alpha blocking agents. One example is tamsulosin or Flomax. This is going to relax the bladder outlet and the prostate gland to open up the ureters to allow that urine to come through. It's really going to enhance that urine flow. Then we have finasteride, which works by inhibiting the conversion of testosterone into androgen, causing the prostate gland to shrink. So you guys should take a look at page 1023, table 55.1, which talks about the different medications. We can also do surgical management. So we can do something called a TURP. I've seen this several times. It's a transurethral resection of the prostate. So this is where part of the prostate is removed with a cutting instrument inserted through an endoscopy. These patients, I've seen 2 patients that have had this, and each time they've had this, I've seen them the next day after the procedure when they've had to come through the emergency room because they weren't able to pee again. So this is an invasive procedure. Obviously, along with that comes a great deal of swelling and edema in that area, which then prevents the patient from being able to pee because there's so much swelling, and then blood. Sometimes they have to go in and they have to wash everything out and go in there and scrape all the blood. And then usually these patients end up in what's called a CBI, which I absolutely love CBIs. I think they're so much fun. It's called a continuous bladder infusion. So you take these, and you're not going to be tested on this, but they take these humongous bags that have 2,000 mLs of fluid in them, and you instill it into the patient. You decide how fast you want it to go by the clamp, and you want it to go at a rate that it's going to allow their urine to be clear. You don't want to see that bright red. So you instill the bag until it's done, and then it's just constantly draining. So it goes in and it comes out through the Foley. It's a 3-way. It's actually pretty cool. I think it's a lot of fun steps. I think, I don't know. I like weird things, but I like doing that. It does take a lot of time. If you have 5 patients, you're in there constantly changing the bag, but still, it's nice to be able to see that you can actually fix someone. So you can, and then when the patient's output is not as red anymore, if it's like a light pink, then they'll slow down the drip, so it'll go in a little bit slower, and then you kind of wait to see. So sometimes you slow it down and you start to see more red, well then you increase it again. So the whole point is that you keep it up until their urine is a very light pink, and then you can remove it from the patient, and then things should just situate on their own. And then so sometimes if you have to catheterize a patient, it can be very difficult if you insert a catheter in a man and it feels like you're hitting something, that's usually their prostate. So normally what you have to do is you just have to keep trying to maneuver it. You have to get that catheter tip around the prostate, which isn't always easy. So sometimes it'll work, sometimes it won't. Sometimes you have to get the GYN cart, and you have to get what's called a Coude catheter. This catheter has a special curved tip on it. So as you're inserting it, it's gonna go around that prostate a lot easier. If you're having this problem with a patient that has an enlarged prostate, so if you're trying to put the Foley in and you don't know he has BPH or a prostate issue, ask them, hey, do you have any issues with your prostate? Oh yeah, I have an enlarged prostate. Okay. Have you ever had a catheter before? Yes. Well, did they have to use a Coude cath? Oh yeah, they did. That's important to know. This is something that the nurse can do. Some nurses don't want to do it because they think it's an invasive procedure. It's not. Urology can do it. I've done it a couple of times. It's really easy to do. So it is in your scope of practice. All right, urinary incontinence. We're going to do this, and then we will take a 15-minute break. So urinary incontinence is bladder and or urethral dysfunction or failure of the urethral sphincters to hold urine. So sometimes those sphincters can contract without urine in them. Sometimes they fail to empty completely. Sometimes there's the inability to be able to control urinary elimination. So you will just be incontinent and you won't be able to control when it happens. Sometimes those muscles become overstretched and they don't contract like they used to hold that urine in. And then sometimes we see that our pelvic muscles start to relax, and then we can have incontinence because of that. So incontinence is the involuntary or uncontrolled loss of urine from the bladder. So table 59.1 and 59.2 is good for you guys to look at. It talks about the types of urinary incontinence and the risk factors for urinary incontinence. So assessment findings, really what we go off for urinary incontinence is what we see or what the patient tells us. So if our patient is completely alert and oriented, they can tell us if they have issues. If they're not, then we would know when we go in to do our physical assessments or to check on the patients every couple hours, we would see that they have been incontinent of stool or urine. So some patients might report that they have urgency. So when they have to go, they can't wait. Or frequency, they go every hour, every 2 hours. They might report that when they cough or they sneeze or they laugh, that small amounts of urine come out. That's stress incontinence. Or they might have the complete inability to hold urine. So they never really know, hey, my bladder's full, I have to go. They never get that. Urine just comes and it releases and they have no control over it. So some diagnostic findings that we might do, we want to try and determine the type of incontinence that they have. So is it because of a medicine? Is it because of some type of issue that they're having? Is it stress incontinence? What type of incontinence is it? So we could do a urine culture and a sensitivity. We could also go in and do a cystoscopy to look around in there and see, observe all the structural units of the bladder and the ureters to see what's going on. Same thing with a cystogram, urodynamics, and or a pelvic ultrasound. For medical or surgical management, this is going to be based upon correcting the disorder that's causing the incontinence. So it could be a variety of things depending on what's causing the problem. We can provide medication to control incontinence. So some medications will improve bladder retention, emptying, and being able to hold on to that, have control over your bladder, works with the muscles. So two of those medicines that we see a lot are oxybutynin chloride or ditropan, and then there's tamsulosin or Flomax. Flomax is also another one of those medicines that we use for blood pressure because it relaxes BP, relaxes the prostate. So it also has the same effect on your blood vessels. Correcting the situational problems that contribute to the incontinence or instituting a bladder control program. So if it's possible, if patients suffer with urgency and frequency, maybe we want to give them a bladder control schedule. So we want to tell them whenever you eat, you should go or drink anything, you should go to the bathroom 30 minutes after, or you should go to the bathroom at 7 in the morning, 9, 10, every 2 hours, make them on a schedule so that they don't have to deal with these issues, especially when they go out, because patients that deal with these issues also suffer from social isolation because they don't want to cause problems for other people when they're out. They don't want to have to always be using the bathroom. It's embarrassing. We can also do something called a sling procedure. So this is where they go in with a piece of synthetic or natural material. It goes under the bladder neck, and then they secure it to the abdominal wall or the pelvic bone, and it kind of creates like a hammock, and the bladder sits in there, and it lifts up the bladder and the urethra. So that they don't have issues of incontinence. That's a pretty popular procedure. So stress incontinence is the most common incontinence in young women. We see it as you get older, and we see it in people who have had children. So you sneeze, you pee, you cough, you pee, you laugh, you pee. Urge is much common in your older adults. Mixed incontinence is pretty common just in the general population, no real age group. And then overflow, we see this when there's any obstruction or the spinal cord is injured. So overflow, as you can see, it's filling, and it, I don't know if you can read what's on there. Yep. It just can't take anymore, and then it won't hold anymore, literally, so it just starts leaking out. Mixed is too much activity and too little tone, so then you start to leak. Urge incontinency is too much activity, which causes the urine to come out, and then too little tone for stress incontinence. Well, then you would do Kegel, when you hear people talk about Kegel exercises, that's what they're talking about for stress incontinence. So we can do pelvic floor exercises. So we can do assisted heel drops. It shows you right on here to do it. Something called a dead bug, the bird dog, and the bridge. So the bridge, you would put your feet on your heels on the ground, and then when you would lift up and strengthen that pelvic muscle. You guys should know these exercises also. All right, so in the male patient, sometimes we can do an external catheter or an external incontinence guard. In the hospital, if we have patients who have incontinence, the thing that we're worried about is what?
Skin integrity.
Yes, skin integrity, skin breakdown. We do not have to go right away and say, oh, my patient needs a Foley because his skin's broken down. No, or if you're afraid of it getting broken down, you can do a condom cath on a male patient. And then you can also do a kind of like an outside female catheter called it's called different things in different facilities, different names.
And the skin breakdown will lead to infection?
Oh, yes, skin breakdown will definitely lead to infection.
Okay.
Yes. So you can do the female external catheter. You could do perineal pads. It says in your book, a disposable incontinent brief. This is okay for your patients who are alert and oriented ×4 and walkie-talkie, who can get up and change their pad when they need it. We do not recommend this for patients who are staying in bed because that constant wetness stays on their skin. Their skin needs to be able to breathe. We can do bladder retraining. We want to offer plenty of fluids, and then we would like to teach them to go to the bathroom at certain times to prevent urgency and frequency. We can recommend Kegel exercises. So this is pelvic floor training. It involves the isometric and pelvic floor strengthening exercises to help with that stress incontinence. And then you guys should go to 59.1 in your book to look about the client and family teaching for those pelvic floor muscle exercises. And then if we have, patients can also do self-catheterization at home if they can't tell when their bladder is full, if the nerve endings don't operate properly, and then they wind up, expelling urine at certain times. We can recommend that they go in and self-cath at certain periods during the day based upon what they're taking in and how much their urine output normally is. So sometimes in the hospital, what we will do is when we are straight cathing them, we do this. It's called a Crease Maneuver. It's where you place your hand firmly but gently above the bladder, and you apply slight pressure, kind of like in a downward motion, kind of like you're massaging it to help expel the retained urine. So if you had a bladder scan that said 600 and only 350 came out, that's kind of a lot to be off with the numbers. So what I would do is while that catheter was still in, I would perform that maneuver and massage the bladder from the outside and push in a downward motion to help expel some of that urine. And usually if that's the case, you will actually get some more urine out. Again, those Kegel exercises, perform 30 to 80 a day for 2 months. Electrical stimulation. So you could have an electrode that's placed in the vagina or the rectum, and then the patient receives a series of electrode impulses that cause the muscles to contract and relax. We see this a lot with patients who have neurologic problems. We can do a pessary ring, which is kind of like a little thing that blows up and it gets put into the vagina to help prevent urine leakage. And then our medications, so ditropan, dibenzoline, uricoline, and Flomax, and then that surgery, that retropubic suspension, and anterior repair. It talks about all these in your book. And then the sling procedure is probably the most common that I see. So nursing diagnoses, we have functional urinary incontinence related to altered environment, so sensory, cognitive, or mobility deficits. Toileting self-care deficit related to cognitive impairment, situational low self-esteem related to inability to control passage of urine, risk for impaired skin integrity, risk factor, presence of urine on perineal skin. All right, so let's stop there. It's 5 of 8. We will come back at 10 after 8. And finish the rest. We don't have too long. We're more than halfway done now. All right, so we are going to finish the rest of our lecture. So we're going to talk about acute glomerular nephritis. So this we see this happen in patients who have some type of an infection. That's usually what starts it off. There's also immunologic kidney disorders that can start in the kidneys. It can be the cause of some type of a genetic issue, or it can also be inflammation. And we also see it as a result of certain health disorders such as lupus, diabetic neuropathy. These can cause injuries to the glomerular. So the assessment findings, signs, and symptoms that we see can include symptoms are not really shown early. They're present very suddenly with pronounced symptoms. So the patient can present with hypertension. The hypertension left untreated can cause convulsions. And some of the things you will see that these patients complain of is blurred vision. So safety is an issue for these patients while their vision is blurry. They can have a fever, they can have nausea, headache, they might have edema. So you can see swelling in the hands, the feet, even that sacroedema in through the abdomen and the back. They can also have periorbital edema. So this is edema around the eyes. Patients that have periorbital edema One thing you can do to alleviate that is to help with it, is to elevate the head of the bed so they're sitting in an upright position, and then that swelling should, that fluid should, trend downwards. They might complain of fatigue. We also might see, because of that edema, congestive heart failure. And this is twice as common in men as it is in women. All right, so laboratory findings that we might see. Patients can present with pink or cola colored urine. This is from the red blood cells being excreted in the urine. We also call that hematuria. We also might see foamy appearing urine from that protein spilling in. So this is excessive serum albumin that's excreted in the urine. It may be dark, smoky, or have frank blood in it. These patients may suffer from oliguria or anuria. So remember, oliguria is low output, 1 to 500 mLs a day. Anuria is less than 100 mLs of urine over 24 hours. We may have to do a percutaneous renal biopsy. So when we go in and we take that piece of the kidney, we are looking for cellular changes. Usually what we see is an antigen antibody response, and that would show us that the extent of damage that has already occurred to the kidneys. So when we do labs, when we check the blood albumin levels, they're going to be decreased because remember, they're spilling so much into the urine. So we're going to have low levels. Our hematocrit and our hemoglobin levels are going to be very low because of the blood. We're going to have an increased level of serum creatinine, an increased bun, because those are going to be reflective of kidney damage. And then we're going to have an increase in that erythrocyte sedimation rate because there's inflammation and they are trying to make more red blood cells. So how do we medically manage this? These patients will be on a sodium restricted diet. Probably in the hospital, that's going to be a renal diet. They won't be allowed to have any salt. If their blood pressure is elevated, dangerously elevated, and they are at risk for convulsions, or if their vision is blurry, we're going to have them on bed rest. We're going to be giving them antimicrobial medications, so antibiotics. We can give different vitamins, corticosteroids to help with that inflammation. And if we think there's an immuno component to this, we will give them those immunosuppressive agents, which leaves them at risk for infection. So you have to be careful with that, and the steroids. They both mask infection. Nursing management, we want to make sure that we are explaining the purpose of diuretic therapy, if that's what we're giving them, to get off that edema. We want to tell them why we're doing it. We want to explain to them that we need them to hold on to their urine because we're doing strict eyes and nose. And then we want them to know, especially if they're a high fall risk or they have problems ambulating, we want them to know that this is going to cause them to urinate frequently. So we kind of need to have a plan. Consult with the provider to determine if a fluid restriction is needed. So we know our patients that have too much fluid or that have congestive heart failure, we don't want them just drinking as much fluid as they want because it can be detrimental to them. So some of them need to have a fluid restriction. Obviously, strict eyes and nose. We're going to be monitoring that blood pressure regularly, probably every 4 hours, depending on how high it is, maybe sooner. Caution the patient to avoid contact with people who have infections because they're on that corticosteroid and those immunosuppressive agents. Emphasize the adherence to keeping all their medical appointments and following through with their primary care physicians. And then for those patients with that periorbital edema, we want to make sure we are elevating the head of the bed to facilitate that drainage of fluid. So then we have chronic glomerular nephritis. So this is chronic inflammation that is going to, over time, lead to the development of these bands of scar tissue. That scar tissue eventually replaces all the nephrons. As a result, we're going to see decreased glomerular filtration, which is eventually going to lead to renal failure. This is a very slow progressive disease. We see that the glomeruli are inflamed, and it's going to cause those bands of scar tissue to develop in place of the nephrons. Sometimes there are two things that your book talks about that can cause this. One is Goodpasture syndrome, and the other is lupus. Lupus is an autoimmune disease. So is Goodpasture syndrome. It affects the kidneys and the lungs, and it makes antibodies that attack them. So your body starts attacking itself. They think that it's a foreign object. Assessment findings in these patients, we may see anasarcia. Anasarcia is a nursing word for generalized edema. We see this edema because of the cause of shift of fluid from the intravascular space to the interstitial and intracellular locations because of protein loss. That is extremely important. You need to know that. You're going to see it on your test, where these patients can remain swollen for weeks, even months. They may present with renal failure symptoms. They also may present with fatigue, headache, dizziness, hypertension, shortness of breath, and visual disturbances as well. Diagnostic findings. Red blood cell count is going to be low. Their BUN and their serum creatinine are going to be increased. Uric acid levels increased. They're going to present with hyperkalemia and hyperphosphatemia. The potassium is going to build up in the system, and there's going to be an increased phosphorus level because of decreased renal excretion of the phosphorus. We're going to see hypocalcemia because calcium is going to bind to the phosphorus to compensate for the increased serum phosphorus levels. Urine tests, we might see our urinalysis might show that they're spilling protein into their urine. It could be, could have sediments in there, so it looks like pus, or it could be, it could have red blood cells and white blood cells in the urine sample. Our creatinine clearance is going to be decreased. If we do any type of a chest x-ray, it might show that because of the CHF, our heart is enlarged, which is typical with CHF. We might have to do an ECG because remember our patient has hyperkalemia. So we know what the side effects are of hyperkalemia. So they're probably going to be on a continuous telemetry monitor, and we're going to want an EKG looking for those abnormal heart rhythms. And then if possible, if we need to, we can go in and do a percutaneous kidney biopsy to go in and see what's going on with the kidneys, what damage has been done. So medical management, it's very important that we administer those antihypertensives. We want to control the hypertension. We want to correct the fluid and electrolyte balance. So they're going to be strict I's and O's. We're going to be doing those electrolyte replacements, some type of fluids, maybe, depending. Reduce the edema, so maybe they're going to be getting diuretic therapy. We want to try and prevent congestive heart failure. So we want to make sure that we are listening for crackles and sounds like that in the lungs. We're looking for those advantageous lung sounds. We want to make sure that they're having good urine output and eliminate urinary tract infections. And then eventually, this can lead to the patient needing dialysis or eventually even a kidney transplant over the long haul. So some nursing diagnosis that we see related to this would be excessive fluid volume related to renal impairment, imbalanced nutrition, less than body requirements related to anorexia and a restrictive diet, and acute pain related to edema of the kidneys. All right, so renal failure is what we're going to talk about next. Renal failure is just that, kidney failure. It's the inability of the nephrons in the kidney to be able to maintain that fluid electrolyte and acid-base balance. They're unable to excrete that nitrogen waste products, and they cannot perform regulatory functions such as maintaining calcification of our bones and producing erythropoietin. So we can have acute renal failure or chronic renal failure. Acute renal failure is very sudden. It happens very quickly, and it's a rapid decrease of renal function, and it is reversible. Acute renal function is reversible. The kidneys can improve over a period of months. You guys need to know that. Acute renal failure sometimes is a consequence of pre-renal, intrarenal, or post-renal disorders. There's a whole bunch of them. There's a table in your book, 58.3. You can go look at that. An example of one thing that we see very commonly is hypovolemic shock. So this is decreased blood flow to the nephrons and kidneys. So when a patient is severely dehydrated and they don't have that good circulating blood volume, the kidneys are not getting perfused, we see acute renal failure. This happens a lot. We see it during the summer. Patients go out and they go kayaking or they go hiking. They do things outside. They don't properly get the proper intake of fluids, and they land themselves in the hospital with an ARF, which is acute renal failure. So acute renal failure usually progresses through 4 phases. We have the initiation phase, the oliguric phase, the diuretic phase, and the recovery phase. So the initiation phase, this starts with the contributing event. So what happened? Was it some type of an injury? Are they just dehydrated from playing sports outside all day? We have the contributing event. It causes a reduced blood flow to the nephrons, which then causes acute tubular necrosis. So this is death of the cells in the collecting tubules of the nephrons. The cells actually die. This initiation phase can last hours or days, just depends on how severe. Then we move into the oliguric phase. So this is where we have excretion of less than adequate urinary volumes. 48 hours after the initial insult or injury, we start to see this oliguric stage, and it can last upwards of 10 to 14 days, maybe even longer. Fluid volume excess is going to develop during this oliguric period. That fluid volume excess is going to lead to edema, which is going to increase your circulating volume and lead to hypertension. And we also see cardiopulmonary complications, swelling, enlargement of the heart, CHF, fluid in the lungs. Then we move into that diuretic phase. This is the recovering nephrons. So this is gradual increased urine output. So little by little, your patient is going to start putting out more urine. This phase typically lasts 7 to 14 days, and then the recovery. So this is where the kidneys continue to recover. This could take 1 or more years until you're completely recovered. Chronic renal failure. We see this related to systemic diseases like lupus or diabetes. Chronic renal failure is progressive and irreversible. So you know the differences between acute and renal. Acute is a very sudden onset and it's reversible. Chronic is very progressive and irreversible. Chronic renal failure has 5 stages. Stage 1 is slight kidney damage with normal or increased filtration, so a GFR of more than 90. Stage 2, mild decrease in kidney function. You're going to have a GFR between 60 and 89. So remember, this is how much waste and stuff your glomerular can filtrate out in a minute. So the lower the number, the poorer your function, your filtration. Stage 3 is a moderate decrease in kidney function with a GFR of 30 to 59. Stage 4 is a severe increase in kidney function with a GFR of 15 to 29. Stage 5 is end-stage renal disease. ESRD is how we write it on our papers at work. End-stage renal disease is kidney failure requiring dialysis or transplantation, and these patients usually have a GFR of less than 15. Older adults, clients are at an increased risk related to the aging process because remember we said as they get older, our older adults have a decreased number of nephrons and a decreased GFR rate. So symptoms and signs and symptoms, we would see an elevated blood pressure, weight gain, so measuring your daily weights, right? This is going to be very important for your chronic or your acute kidney injury patient, weight gain. fluid retention, bleeding. They might also report just some vague symptoms. So lethargy, they might be tired all the time. They may complain of a headache. They don't really have an appetite. So anorexia, they might state that they have a dry mouth, very vague symptoms. Their urine output is going to be decreased. Their facial features may appear puffy because of that fluid retention. Initially, their skin is going to be pale, but later their scale is going to be very dry and scaly. They might even get pruritus. Alteration and bleeding from the GI tract may happen, so we may see blood in the feces. The oral mucous membranes may start to bleed. They may have breath and body odor characteristics of, they may smell like urine. Muscle cramps, bone pain, and tenderness, or these patients are at an increased risk for having a spontaneous fracture. This is because of the levels of the because of the elevated, levels of phosphorus in the blood. So that's important. You guys need to know that spontaneous fractures can occur because of those elevated levels of phosphorus in the blood. Remember, we said they would have hyperphosphatemia. And then mental processes can be typically slower because these patients have those electrolyte imbalances and they have nitrogen waste that begin to accumulate in the body because the kidneys are not functioning, so we cannot get rid of the waste. So the waste builds up and it's toxic. So some diagnostic findings that we would look at are laboratory tests, our BUN, our serum creatinine, our potassium, our magnesium, and our phosphorus are all going to be elevated. Decreased is our calcium, because remember, calcium binds to the phosphorus. Our red blood cell counts are going to be low. Our hematocrit, our hemoglobin, and our urinalysis, if we did one, is going to show a decreased specific gravity. The glomerular filtration rate is going to be decreased. For procedures, we could do that IV percutaneous renal biopsy if we needed to go in there and take a sample of the kidney to see what was going on and how far it had been damaged. We can do x-rays to visualize all the, the ureters, the bladder, all those important features. We could do an ultrasound or that renal angiography, which goes in and looks at the vessels and the arteries leading to the kidneys. These patients also develop something called...
Sorry, are you able to let Ryan back in?
Oh, yes.
Thank you.
Yep. Okay, these patients also develop something called osteodystrophy. So this occurs when their bones in their body become demineralized. So it starts because they have low calcium in the blood and they have that hyperphosphatemia, so that high blood phosphate. And we know that the calcium binds to the phosphorus levels and then causes this demineralization of the bones. So this is just a cute little slide that tells you, what your patient could look like that has chronic renal failure. So kidney damage with let's say their glomerular filtration will be less than or greater than 90 mLs per minute. That's not right. We just said it was going to be decreased, didn't we? Yes, 90 is going to be normal. Less than 90, it goes backwards. So the lower the number, it correlates with, I'm not sure why it says that. Maybe that's what they want you to have. You want to have no kidney damage and a normal GFR. You're going to see, that really doesn't make sense. I don't really like that slide. I didn't put that in there, but I kept it, but whatever. The glomerular filtration rate, as you get further and further into this chronic renal failure through the stages, that number is going to get lower and lower. You want to have an increased GFR with no kidney damage. You're going to want to watch the blood pressures, like we said, maybe that 24-hour urine, and then definitely treat those other issues, the diabetes, if they have renal artery stenosis and hypertension. Retention. All right, so preventative measures, we want to teach these patients depending upon what stage they're in. We want you to always be able to have the adequate amount of water in your diet so that you can perfuse your body and have appropriate circulating volume. So in a healthy, normal person with no kidney issues, we want you to drink at least 2 liters of water daily. Now, if you have CHF, that's probably not appropriate for you, but just saying for the normal healthy adult, preventative measures, drink at least 2 liters of water a day, stop smoking, limit your alcohol intake, make sure you're taking any of your medication prescriptions according to how they're prescribed because you want to prevent kidney damage. If you're taking antibiotics, make sure you take them all until it's completed, and then limit your over-the-counter intake of NSAIDs. Medications we may give, well, we might be giving K-Exalate because this is going to help remove the excessive potassium. It'll be excreted in their stool. And then we want to give Epogen. So patients that are on dialysis, typically after dialysis is done and they come back up to us, we give them an injection in their belly. It's a subcutaneous injection of Epogen, and it helps to stimulate bone marrow production of red blood cells so they don't have the issues with anemia. Depending on what stage they're in, they might be getting hemodialysis or peritoneal dialysis. We're going to talk more about that. We want their diet to be high in carbs and moderate fats. We want to control their protein intake. We want to restrict their dietary sodium, their potassium, their phosphorus, and their magnesium. So they really have to monitor their diet. Surgical management, we could give them immunosuppressive medications if they had a transplant to keep it from rejecting. And then obviously we could do a transplant if that is necessary. So nursing diagnoses for chronic kidney disease, we can have excess fluid volume related to impaired renal function, risk for imbalanced nutrition less than body requirements related to anorexia, increased metabolic needs and dietary restrictions, risk for impaired tissue integrity related to restricted oral intake and nitrogenous waste in the body fluids, such as saliva, activity intolerance related to fatigue, anemia, weakness, retention of those waste products, and dialysis procedure. Risk for impaired skin integrity related to scratching secondary to pruritus. Remember, we said as they get further into the chronic kidney disease, they can develop pruritus and dry, scaly skin. Risk for infection related to compromised immune defenses, situational low self-esteem related to change in body image dependence, and role change. So you should go to page 1089 on your book and look at the care plan for the client with chronic kidney disease. So we did say that sometimes our patients will require a kidney transplant. So donors who for a transplant are selected from a compatible living donor, or these patients may or may not be relatives. So the greatest chance of a graft survival comes from a compatible relative. We can also get these organs from donors who are brain dead and whose next of kin give permission for harvesting organs. So if you're an organ donor and your family knows that, and your power of attorney or your whoever takes over your advance directive can donate your organs for you if they knew that that was your wish. They do a lot of in-depth tissue typing. So they want to look at the blood type. They want to look at compatibility and a histocompatibility. They look at the human leukocyte antigen and other minor antigens, which could cause problems with the patient being able to we want them, it can cause them to reject the kidney that they get. Any potential donor with a history of hypertension, malignant disease, or diabetes would be excluded from the donation, and for obvious reason, because these cause issues with the kidneys. To be able to facilitate matching a recipient with a donor, the patient is placed on a national computerized transplant waiting list. and they have to wait behind other people for a compatible kidney. Kidneys used from cadaver or non-heart-beating donors must be sufficiently perfused to maintain viability of the organ. So this is the donor and this is the recipient. So you can see they would take one of the donor's kidneys. You can see in the recipient, these two kidneys here are very damaged. We don't take one out and replace it. We just put it further down here. This is where it gets transplanted at. So we don't actually remove one and put it there. It comes a little bit further down. So we talked about some patients needing dialysis. This is an actual picture of a patient that is getting dialysis. So dialysis cleans and filters the blood. It acts as the filtration system for the kidney because now the kidneys can't remove the waste products and maintain that adequate fluid, electrolyte, and acid-base imbalance. So we have to put them on acid, we have to put them on dialysis, and this does the work of the kidneys. Usually this procedure takes about 4 to 6 hours, and we do this about 3 to 4 times a week. This is very hard for patients to have a normal life around a dialysis schedule. We can do something called peritoneal dialysis. So there's 2 types of peritoneal dialysis, and I'm going to show you pictures. So peritoneal dialysis works by installing we instill a hypertonic diacylate solution into the peritoneal cavity of the patient and different dwell times. So we put this diacylate solution in and it dwells for a certain amount of time. What it does is when it's dwelling, it's grabbing all the toxins that are supposed to come out and it grabs them and pulls them into this fluid. And then after a certain period of time, depending on what type you're getting or how often you do it, you will then drain it back into another bag. The peritoneum is going to serve as that filtration membrane. So we have continuous ambulatory peritoneal dialysis or continuous cyclic peritoneal dialysis. So where's my picture? So here's my picture. So here's the patient's abdomen. This is the dialysate. This is a special formula, a hypertonic solution. They have a catheter that stays in their abdomen here, kind of like a JPEG tube. It looks like that a little bit. It stays there all the time. They connect this to that ending, to that port, and they hold this bag up and they let it instill. So it depends on. It can take 30 minutes, it can take 60 minutes, it can take an hour. It just depends on how much has to go in and how the patient is used to doing it. And then it's going to sit in there, and you can see the next picture here. There's the dialysate, and it's mixing with all the waste and the fluid and the chemicals. You see all that's going in there. It's expanding, and then after a certain amount of time, I'm sorry, this crazy dog keeps barking. The dialysate is then going to be drained out. Sometimes they do this three or 4 times a day. Sometimes they do it overnight for 10 to 12 hours, and then they just drain the bag once. It just depends. The patients really decide how often they want to do it, depending on what type they need. So now that you have a good picture of how that looks. So the continuous ambulatory peritoneal dialysis, this is where they take 2,000 mLs of dialysate and they install it by gravity in 30 to 40 minutes. The clamp should always be open during infusion because you want all that to infuse in the abdomen. So you want the clamp open. After the bag is empty and everything goes into your abdomen, the catheter is then clamped and the solution dwells anywhere from 4 to 10 hours. It depends on what your patient is used to. After that time, you hook them back up. The bag is lowered. So you want kind of like your Foley, it's below the level of the catheter in your abdomen. You unclamp it, usually about 30 to 40 minutes, and it allows the gravity to drain into the bag. So it's done by gravity. This is repeated 3 to 4 times a day. A machine is not required for this process. You need to use strict aseptic technique. So you should wear a mask if you have any type of respiratory infection in the hospital setting. They always have to wear a mask. I always have to wear one when we're clamping and unclamping. Other than that, once everything's put together and clamped, we don't have to wear a mask. The fluid should be allowed to drain by gravity. So you don't want to keep it up. You don't want to force any fluid out. You just want to connect it to that empty bag, drop it on the floor, and let it drain. The diacylate solution is warmed approximately to body temperature. You never ever want to put it in a microwave. Usually what I do is I leave it out at room temperature. If it has to be warmed up a little bit, you can do it with dry heat. So a warm washcloth, a heating pad, something like that. Then you have continuous cyclic peritoneal dialysis. So this gives the patient a little bit more independence, because normally if they do this at night, they're only doing one of the ambulatory peritoneal dialysis during the day. Some patients never have to do it during the day. They just do it at night. Again, it just depends on the severity and what the patient's used to. For this, you need a machine. This is connected to a dialysis catheter, which is going to deliver that dialysate to the patient. You drain the peritoneum via another dialysis catheter. This happens 3 to 5 times during the night while the client sleeps. So it happens over a 10 to a 12-hour period. And this also needs a strict aseptic technique. So the intermittent peritoneal dialysis, it happens periodically. Some clients can opt to use the APD at night and then they do the continuous cyclic one during the day. Clients can also change systems if not satisfied or if there's a change in their schedule. So that gives them a little bit more independence instead of going to dialysis 3 times a week for 4 to 6 hours a day. So then nursing management, we want to make sure that we are doing the proper procedure for instilling and draining this fluid. If you have a patient that comes in and you've never done peritoneal dialysis, obviously you want to ask a nurse, but also ask the patient, because they do it at home usually. So they can definitely direct you on how they like to have it done. You obviously want to observe for major complications. One of the biggest things we watch for is peritonitis. So this is an infection of the peritoneum. Peritonitis would result in a fever, nausea, vomiting, severe abdominal pain, not just a little bit of cramping, but severe abdominal pain, abdominal rigidity and tenderness before, during, or after dialysis. So I want you guys to go to page 1095 in your book and look at nursing guidelines for performing peritoneal dialysis. That's good for you guys to know. And that picture is in there, which I think is helpful. So then patients can choose to do hemodialysis. So this is where we shunt blood from the body through a dialyzer and back into the circulation. In order for a patient to have hemodialysis, they have to have some type of vascular access. So sometimes if the patient is just going to be getting hemodialysis on a temporary basis, we might put in like a central line. We call it an HD cath. That'll go in the chest. It's like a regular central line, except we as nurses don't use it. It's just for, it has a little brown port on it. We call it a piggyback, and that's just used for hemodialysis only. We still change the dressings on it, but we don't access that area. We don't access that lumen. It's going to restore the electrolyte balances because it's going to remove the excessive sodium, potassium, fluids, and waste products, and it helps restore that acid-base balance. The cycle usually takes, like I said, about 4 to 6 hours, and we usually do it 3 times a week. So some patients can get what we call an arteriovenous fistula or an arteriovenous graft. These are usually put in if the patient is going to have hemodialysis on a long-term basis. So fistulas are normally preferred over a graft because they have a better record of staying patent. There's a fewer risk of complications. such as a bacterial infection or developing a thrombosis. So we prefer fistulas, but the down part about fistulas is that after you get one, it's 1 to 4 months for them to mature before you can actually use them. An arteriovenous graft is another vascular access method. This is where they take a tube of synthetic material to connect a vein and an artery in the arm. So with the fistula, they're doing a surgical anastomosis, which is a connection of that artery and vein. With the graft, it's just they're connecting the artery and the vein together with some synthetic material. So as you could guess, it doesn't last as long, maybe 3 to 5 years. And then, but the advantage is that you can use it 14 days after it's placed. So nursing management, we always want to prepare the patient for vascular access. So we want to make sure that their dressing is good, it's clean, dry, and intact, that it's been changed when it's supposed to. We want to monitor their vital signs and their laboratory changes. So usually in the morning, before we know they're going to dialysis, we're looking at their bun, we're looking at their creatinine and their electrolytes and their red blood cell count, hematocrit and hemoglobin. So we always want to know their blood pressure. Some people have very soft blood pressure and they have to have hemodialysis very, very slow, or sometimes they have to divide it up between half in the morning and half during the day because the blood pressure drops too low, because obviously we're removing circulating volume and then putting it back in again. So there's always that risk for that hypotensive issues to occur. These patients that are in need of dialysis, it is not uncommon for them to have critical bun and critical creatinine levels, upwards of 7 to 8 we've seen, and normal is 1.3, 1.2, depending on where you're at. So 7 is very high. So their kidney function is severely compromised. And we know that the kidneys aren't working, so it's not going to get rid of the toxins, the electrolytes, and they're going to have anemia because it can't make the proper red blood cells. We want to assess for complications. So when they come back, we want to make sure that they don't have low hypotension. Usually they'll call and give you a report. They'll let you know how much they took off, how the patient's doing, and what their blood pressures were. They usually take about 3 or 4 blood pressures before they send them back to you to make sure they're stable. Sometimes we see clotting of the vascular access device. That's just a common finding. They can report headaches, muscle cramps, and then bleeding is also an issue. So we want to make sure, we want to teach the patients about caring for their AV fistula or AV graft precautions. So keeping it covered with a dressing, things like that. So one of the other things I want to tell you too is if they have an AV fistula or an AV graft precaution in their arm, that patient is going to be, whatever arm it's in, it's going to be, if it's in the left arm, it's going to be no left arm procedures. If it's in the right arm, obviously no right arm procedures. So that means you don't want to put IVs in that arm. You don't want to draw blood from that arm. You don't want to do blood pressure in that arm. No other procedures, because any type of procedure, like I just talked about, can compromise the stability of that fistula or that graft. So when they come in and you see that, you should put the signs on the door above the bed, and you should also put like a little blanket, a little bracelet on their wrist that says upper extremity restrictions. So patients that get hemodialysis dialysis can also have something called disequilibrium syndrome. So this is a neurological condition, and we believe that it's caused by an influx of fluid that causes cerebral edema. So when the concentration of the solutes in the blood are lowered rapidly, like during dialysis, we see a shift in the cerebral fluid in that volume. The decreasing solute concentration lowers that plasma osmolality. Water then floods the brain tissue. A great deal of fluid goes into that brain tissue. These patients complain of headache. They may be disoriented, confused. They can become restless. They may report blurred vision, and they might even have a seizure depending on how bad it is. The good thing about this is that the symptoms are usually very self-limiting and they disappear within a couple hours after dialysis has completed, and you have time for that fluid and solute concentration to equalize again. The syndrome can be prevented by slowing the dialysis process to allow time for gradual equilibrium of water. So sometimes your patient will be gone. Like, I feel like 4 hours is a really adequate time for dialysis. Sometimes they're gone for 6 or more hours. Usually when that happens, it's because they have to go super slow delivering that dialysis and doing that procedure because the patient can't tolerate it. And they usually tell you that and report when they call you. So this is what the filter looks like that filters your blood and all the toxins out. And then this is what the actual dialysis machine looks like. If they go to an outpatient center, certainly they can sit in these chairs. In the inpatient setting, you usually send them down in their bed or their stretcher, and they stay on that for the duration that they are there. And the thing about this too, from the nursing aspect, is you want to think about when you're giving them medications. So in the morning, when you see your patient's medications, you should call dialysis and say, hey, I see that my dialysis patient gets dialyzed today. What time do you have him in for? So if he's in for 4 o'clock in the afternoon, you can give the morning medications. That would be fine. But if he's coming in at 10 or 11, you never want to give their morning medications, because when they go through dialysis, dialysis is just going to pull them all off again. So you definitely want to hold those morning medications if they're going in the morning or the early afternoon. So these are just your fistulas. It shows you how they work, and then it shows you how the blood goes in from the machine, from the dialysis machine, and how it goes back through the machine again. How it goes in and how it comes out. So we want to make sure that we are inspecting the skin over the fistula or the graft. So we want to make sure that it's not swollen. It could be a little puffy because you might feel that fistula in there, but it shouldn't be red. It definitely should not be oozing anything. You want to assess the patient for fever, any kind of swelling or drainage. The other thing you want to do is you want to, as the nurse, you're going to palpate for a thrill, and you're going to listen for a bruit. So when you palpate for a thrill, you should be able to put your fingers over the vascular access and feel a vibration, and you will be able to feel the blood flowing through that area. You can also listen for a bruit, which is a loud swishing sound caused by the blood flowing through that area, and it just sounds like so you want to make sure that they have a bruit and a thrill. If they don't, then that means that the fistula could be compromised, and they probably are not going to be able to use that. So if you notice that one of those or both are absent, you're going to postpone the dialysis and then report those findings to the doctor. You want to make sure you're notating the color of the skin and the nail beds and the mobility of the fingers. We're assessing for edema and dryness, pruritus. We want to wash the skin over the fistula or the graft with soap and water or an antiseptic. Want to keep it clean. We want to make sure we are observing for that disequilibrium that can occur. So that's that altered level of consciousness. We're going to monitor for hypotension because of that rapid change of fluid and electrolytes. And then we're going to decrease the dialysis exchange rate to slow the rapid changes in that fluid and electrolytes. After dialysis is completed, we usually try not to administer injections for 2 to 4 hours. This is going to allow time for metabolism and excretion of the heparin, which is administered during dialysis because they don't want any blood clots developing. So usually 2 to 4 hours for any type of injection that you would need. You would want to review your bun and creatinine levels to determine waste products that remain. So obviously, if we did creatinine levels today and they were 7.5, we would want to run them again in the morning to make sure that the creatinine levels have dropped, and they should significantly if they've had dialysis. We're going to watch for hypovolemia, which is due to that rapid decrease in fluid volume. So we're going to be looking for increased heart rate, low blood pressure. We want to make sure we're checking that site for bleeding. And then, like we said earlier, never obtain a blood pressure on the extremity that has access because it could collapse the AV fistula or the graft. And then before discharging the client, so this would be in the outpatient setting, observe for the disequilibrium syndrome, which is that serious potential complication. And then when you're accessing the AV sites, you want to avoid puncturing the same site that was used previously. And you can usually see on there like a little scab of where it was punctured before. And then you want to inform the client to avoid lifting heavy objects with the access site arm because it can damage that fistula. So some hemodialysis nursing diagnoses, we could see ineffective coping related to situational crises, excess fluid volume related to renal disease with minimal urine output, powerlessness related to treatment regimen, risk for electrolyte imbalance, potassium changes can be very life-threatening for our patients, so that's a big one you want to watch for. Risk factor effect of metabolic state on renal function, risk for deficient fluid volume, excessive removal of fluid during dialysis, risk for infection, exposure to blood products, risk or developing hepatitis B or C, an impaired immune system, or risk for impaired tissue integrity. Risk factor, mechanical factor associated with fistula formation. All right, which of the following are indicative of decreased renal function? How about A, elevated serum creatinine? What do you guys think? If a patient had elevated serum creatinine, is that indicative of decreased renal function?
Yes.
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 Yes, it is.
Yes, very good. Elevated thrombocyte cell count.
Row.
No.
B, no.
No,
Yeah, no.
it would be decreased. Yep. Decreased red blood cell count.
Yeah.
No.
Yes.
Yes.
Yes. Decreased white blood cell count.
No.
No, it'd be increased.
No.
It wouldn't be anything. Doesn't even have an effect on it unless there could be an infection, but we're not going to talk about that. So no, it would be normal. And then an elevated BUN, blood urea nitrogen.
Yes.
Yes. Very good. All right, guys. We actually finished a little earlier. It's 9 o'clock. That's good.